Welcome to this Q&A review for the ATI Adult Medical Surgical Exam. For every question, we break down why it's right, why the others are wrong, and the reasoning behind it. We'll cover foundations of nursing care, including health and wellness concepts, emergency and triage care, fluid and electrolyte balance, acid-base imbalances, perioperative nursing care. Our website is loaded with free study guides and practice questions designed to help you ace your ATI Adult Medical Surgical Exam. Everything you need is right there, just a click away, and you'll find the link in the description below. Go check it out, study smarter, and get closer to passing today. Alright, let's get started. Question 1. A nurse is teaching a community group that wellness is the ability to adapt to a changing state of health. Which of the following client situations best reflects this concept? Your options are A client refusing any health screening. B. A client with controlled arthritis living fully. C. A client with no chronic conditions ever. D. A client measured against an absolute standard. Which one is it? Pause the video if you need more time. The correct answer is B. A client with controlled arthritis living fully. B is correct because wellness is relative to a person's own baseline. So a client whose rheumatoid arthritis is well controlled and who functions at an optimal level with a positive outlook is demonstrating health within a chronic disease. A is wrong because refusing health screening shows a barrier to health maintenance rather than adaptation. This behavior reflects an obstacle to compliance, not the capacity to adjust emotionally and physically to a shifting state of health. C is wrong because the absence of chronic conditions is not what wellness means. Health is judged against the individual's usual functioning, and a person living with disease can still be considered well while another without disease may not be. D is wrong because comparing a client to a fixed external standard ignores that wellness reflects a person's own baseline. Health and wellness are unique to each individual and relative to that person's own usual state, never set against one universal measure. Wellness is not the absence of disease. It's the relationship between what you can currently do and what you personally are capable of at your best. Picture a woman with a decade-old arthritis diagnosis who still runs her church's front desk, and a man down the hall with no diagnosis who hasn't left his apartment in weeks. The chart says one has a disease, but the functional picture says the other is further from wellness. One trap treats an undiagnosed person as automatically the healthiest, judging against an external standard instead of a personal one. The other trap treats refusing a health screening as adaptation, when refusal actually removes information rather than adjusting to it. Students lose points blurring three ideas. Cure is the elimination of disease. Health is the broader state of physical, mental, and social well-being. And wellness is the active process of functioning at your own highest level, disease or no disease. Cure is a finish line, but wellness is a direction of travel. A person can be moving the right way while still carrying the diagnosis that started the journey. Question 2. A nurse is planning health promotion teaching for a client. Which of the following client characteristics is a modifiable variable that the nurse should target? Your options are A. The client's age. B. The client's genetic traits. C. The client's smoking on social occasions. D. The client's developmental level. Take a second. Which answer would you pick? The correct answer is C. The client's smoking on social occasions. C is correct because smoking is a modifiable variable that the client can change. So it is an appropriate focus for nursing interventions such as cessation teaching. Nursing efforts aim at behaviors a person has the power to alter. Is wrong because age cannot be altered and therefore sits in the non-modifiable category. Teaching cannot change a person's years, so health promotion does not direct its energy toward this fixed characteristic. B is wrong because genetic traits are inherited and unchangeable, placing them outside what interventions can address. Genetics belongs among the non-modifiable variables, the opposite of the behaviors nurses help clients adjust. D is wrong because developmental level reflects a stage tied to growth and cannot be modified through education. Unlike smoking or nutrition, this characteristic is fixed, and so is not the object of health promotion efforts. Health promotion planning sorts every risk factor into two buckets, modifiable and non-modifiable. That split isn't academic. It decides where a nurse actually spends her limited teaching time. Modifiable variables are behaviors like smoking, diet, activity level, alcohol use, stress management, and medication adherence. Non-modifiable variables are fixed traits like age, sex, genetic inheritance, family history, and developmental stage. The test is simple. Ask whether a plan of care could plausibly change the trait. If yes, it's a target for teaching. If no, it's context that raises the stakes but never the action item. Picture an intake sheet for a man in his late 40s. His age, his father's heart attack at 50, his build, and weekend smoking. 3 entries are history. Only the smoking line will read differently a year from now. Age, genetics, and developmental stage shape how teaching is delivered, but they are never what the teaching targets. Only behavior is. Remember, a variable that influences care is not the same as a variable that receives care. Question 3. A nurse is reviewing the illness-wellness continuum with a group of clients. Which of the following clients should the nurse identify as positioned at the center of the continuum? Your options are A client newly diagnosed with diabetes, B, a client with active influenza, C, a client with a urinary tract infection, D, a client with well-controlled rheumatoid arthritis. Before I reveal it, which one do you think is right? The correct answer is D, a client with well-controlled rheumatoid arthritis. D is correct because the center of the illness or wellness continuum represents a client at their normal state of health. A client whose rheumatoid arthritis is well controlled is functioning at baseline and therefore occupies that central point. A is wrong because a fresh diabetes diagnosis moves a client away from their usual baseline toward the illness side as they begin adjusting. This position reflects a shift from normal, not the centered state of health. B is wrong because active influenza pulls a client toward the illness end of the range because acute symptoms reduce functioning below the personal norm. The center is reserved for someone at their typical level of health. C is wrong because a urinary tract infection signals an acute decline relative to the client's usual condition, shifting placement off-center. The middle point describes a person operating at their baseline, which infection disrupts. The illness-wellness continuum places health along a single line instead of sorting it into boxes. On one end sits premature death, on the other high-level wellness. The center marks a neutral point, and a person moves along this line constantly in both directions. Traditional medicine treats the neutral point as success. Illness appears, treatment ends it, and the encounter is done. That leaves nothing to say to someone who isn't sick. The continuum extends the line rightward, adding awareness, education, and growth as a path toward high-level wellness. Picture a nurse in Milwaukee drawing this line for a class. A man with pneumonia goes far left. A woman who just learned she has diabetes sits slightly left of center. A man whose arthritis has been stable for years sits right at the neutral point. And a woman chasing more than absence of illness moves right. The neutral point isn't perfect health or an absence of diagnosis. It's a person's own normal baseline. A stable, well-controlled chronic condition belongs at the center, while a brand new diagnosis moves someone leftward, because the adjustment itself disrupts sleep, appetite, and mood, even before any physical decline. Don't confuse this with the adaptive definition of wellness. That model judges whether someone is well. The continuum simply maps their current position and direction of travel. Question 4. A nurse wants to promote compliance for a client who struggles to follow a diabetic diet and remember medications. Which of the following actions should the nurse take? Your options are: A. Encourage use of a daily medication dispenser. B. Assess for age-related cognitive awareness. C. Tell the client non-compliance causes complications. D. Limit the client's involvement in planning. What's your answer? Commit to one before I continue. The correct answer is A. Encourage use of a daily medication dispenser. A is correct because a daily medication dispenser reduces health risks and improves medication compliance by helping the client organize and remember doses, which directly addresses the difficulty described and supports adherence at home. B is wrong because checking cognitive awareness gathers useful data but does not by itself enhance compliance. This step is important assessment rather than an intervention that strengthens a client's ability to follow the plan. C is wrong because warning about complications relies on fear and can damage the trust that supports adherence. Building coping and support systems aids adherence, unlike pressuring a client with threats of bad outcomes. D is wrong because restricting the client's role in planning removes the engagement that builds confidence in therapy. Compliance grows when clients participate and feel supported, so sidelining them works against the intended goal. Compliance describes whether a client's behavior matches the care plan, but many programs now say adherence instead, and that word choice carries the real point. Compliance implies obeying instructions handed down. Adherence implies a plan the client helped build and still stands behind. The gap between prescription and behavior is where chronic disease management usually fails. Roughly half of clients with chronic conditions fall short of their regimens over time, so closing that gap often helps more than switching medications. Nurses own this territory because they see the practical obstacles a brief provider visit never surfaces. Improving adherence has 3 parts, and only one involves information. First, simplify the task with pill organizers, blister packs, alarms, or routines anchored to existing habits. Second, build the client's confidence so the plan feels achievable. Third, protect the relationship because a client who trusts the nurse will honestly report a missed dose. Picture a man in his 60s managing 4 medications at 3 different times a day. He isn't defiant or confused. He's simply losing track while running a household. What changes his numbers is a pill organizer filled every Sunday and a phone alarm at the same hour daily. Structure carrying the load memory was dropping. Exam writers test the difference between assessing a barrier and removing one. So a STEM asking what promotes compliance wants an action, not more data collection. Fear-based warnings backfire, damaging trust and honest reporting. The skill being tested is matching the actual barrier, ignorance, forgetting, affordability, or trust to the right intervention. Question 5. A nurse is talking with a client who was newly diagnosed with breast cancer. Which of the following statements indicates the client lacks understanding of the illness? Your options are: my grandmother also had this disease. B. The hospital is far away. C. There is no lump. I refuse this. D. I must rearrange my work schedule. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is C. There is no lump. I refuse this. C is correct because insisting there is no lump and demanding another opinion reflects denial, a response that shows the client has not accepted the reality of the diagnosis and lacks understanding of the illness experience. It is wrong because mentioning a relative's history shows the client recognizes a risk factor and is processing family relevance. This awareness can shape the response to illness but does not amount to refusing the diagnosis. B is wrong because noting the distance to the hospital raises a practical access concern about health care, not a rejection of the condition. Such practical logistics influence how a client responds rather than signaling denial. D is wrong because planning to adjust a work schedule signals the client is accepting the diagnosis and arranging life around treatment. This adaptive step is the opposite of failing to grasp the illness. When someone learns they're sick, how they respond isn't random emotion, it's a predictable process. Nurses who understand this process can tell what a client actually needs, instead of mislabeling them as difficult. Illness behavior unfolds in recognizable stages: experiencing symptoms, assuming the sick role, contacting the healthcare system, moving into a dependent role during treatment, and finally returning toward recovery. Recognizing which stage a client occupies tells the nurse what they need right now. Picture 4 women in a breast health center, all given the same diagnosis. One asks about screening her daughters. One worries about transportation. One needs to adjust her work shifts. And one insists there is no lump and asks for a different doctor. 3 have accepted the diagnosis and moved into logistics or recognition. Only one is rejecting the facts. The test is simple. Does the statement contradict what the workup found? Denial rejects the physical reality of the diagnosis, demanding it be undone. Anger, fear, and worry about logistics are not denial. They're signs the client already understands and has moved further along. Denial calls for calm presence and repeated honest information, never confrontation, while practical worries call for problem solving and anxiety calls for support. Knowing the difference is what separates a targeted nursing response from a wasted one. Question 6. A nurse is triaging clients in the emergency department. Which of the following clients should the nurse assign to the resuscitation level requiring immediate treatment to prevent death? Your options are A client in cardiac arrest, B, a client with a kidney stone, C, a client with a bladder infection, D, a client with a minor skin rash. Which would you go with? Lock it in before the reveal. The correct answer is A, a client in cardiac arrest. A is correct because cardiac arrest is a resuscitation level situation because it needs immediate treatment to prevent death. The most life-threatening conditions are placed at this highest triage priority, so the sickest clients receive care first. B is wrong because a kidney stone falls under the urgent level because it requires treatment, yet is not life-threatening. This intermediate category ranks below the immediate death-preventing care that resuscitation demands. C is wrong because a bladder infection is a less urgent problem that can wait without immediate harm. Placing it at the resuscitation level would misjudge its severity, since it poses no imminent threat to life. D is wrong because a minor rash belongs at the non-urgent level, needing only simple evaluation and minor management. It is the least acute presentation and the opposite of a condition threatening death. Emergency triage sorts clients by how fast they will die without help, not by how sick they look or how long they've waited. 5 levels exist so that the sickest clock runs out first, not the longest wait. The system exists because a waiting room sorted by arrival time would place a man in cardiac arrest behind a woman with a sprained ankle. Military medicine worked this logic out across wars, and civilian emergency care adopted it: treat whoever's clock is shortest. Level 1 means an immediate life-saving intervention is happening right now to prevent death, like chest compressions or intubation. Level 2 means the client is high risk and unstable, but still breathing and perfusing, with a short window to assess before acting. The test is simple. What is happening in the next 60 seconds? Picture a nurse at shift change, a pulseless man mid-compressions, a woman with an amputated hand who is awake and has a strong pulse, a man clutching his chest, and a teenager with a swollen wrist. The compressions that never pause mark level 1. The amputation and chest pain are emergent, and the wrist waits. A traumatic amputation looks catastrophic, but the person still has a pulse and an airway, while a cardiac arrest can look quiet. Triage level tracks the failure of vital functions, not the drama of the injury. Question 7. A nurse is triaging a client who has a traumatic limb amputation. Which of the following triage levels should the nurse assign to this client? Your options are A. Non-urgent, B. Emergent, C. Less urgent, D. Urgent. Don't overthink it. Which one feels right? The correct answer is B. Emergent. B is correct because a traumatic amputation is emergent, a problem needing time-sensitive treatment because it has the potential to become life-threatening or limb-threatening. Rapid intervention protects both the client's survival and the affected extremity. A is wrong because the non-urgent level covers simple problems like a rash that need only minor management. Assigning a traumatic amputation here would gravely underestimate a limb-threatening injury that requires prompt care. C is wrong because less urgent describes conditions such as a laceration that can safely wait. An amputation cannot wait without risking the limb and life. So this category fails to match its time-sensitive nature. D is wrong because the urgent level fits problems that need treatment but are not life-threatening, like a fracture. A traumatic amputation carries limb-threatening potential beyond this tier, placing it one level higher. Between clients who are actively dying and clients who can safely wait sits a large, dangerous middle ground. That's the emergent level, level 2 in the 5-tier system. 3 features place a client at level 2. High risk to life, limb or organ function while still compensating, severe pain or distress on its own, and new confusion or disorientation that hasn't yet compromised the airway. Any single one is enough. Picture a man arriving after a farm accident with his forearm severed below the elbow. He's pale, frightened, but speaking in full sentences, his radial pulse is strong, and a co-worker has held firm pressure on the stump the whole way in. Nothing demands a life-saving intervention this minute, but everything demands a trauma bay within 5. The signal words to remember are high risk, could deteriorate, severe pain, new confusion, time-sensitive, and threat to life or limb. Presentations that reliably land here include traumatic amputation, chest pain concerning for infarction, stroke in the treatment window, active GI bleeding with stable vitals, and suspected sepsis while still holding pressure. A conscious client with a patent airway is not a resuscitation case, and a client with a severed limb is not a can-wait case. What separates emergent from urgent isn't how loud the presentation is, it's what a delay would cost. Question 8. A nurse is performing a primary survey on a client following a motor vehicle crash. Which of the following assessments should the nurse complete first? Your options are A. Level of consciousness, B. Skin temperature, C. Capillary refill, D. Airway patency. Got a guess? Lock it in. The correct answer is D. Airway patency. D is correct because airway is the first and most important step of the primary survey. Without a patent airway, every other step is futile, and hypoxia causes brain injury or death within only a few minutes. A is wrong because level of consciousness is the disability step that comes after airway, breathing, and circulation. Checking neurologic status before securing the airway would delay the action that prevents rapid hypoxic death. B is wrong because skin temperature relates to exposure, the final stage of the survey. Assessing for hypothermia matters later but cannot precede establishing the airway that keeps oxygen reaching the brain. C is wrong because capillary refill belongs to the circulation step assessed after breathing is confirmed. Perfusion is meaningless if no air is moving, so the airway must be addressed before circulation checks. Every trauma client gets the same fixed order assessment the moment they arrive, built to find and fix whatever kills fastest first. The order runs airway with cervical spine protection, breathing, circulation, disability, and exposure. It is not a checklist to complete in any convenient order. It is ranked by how fast each threat kills. Before this discipline was standardized, teams chased the most visible injury. Clients died with perfectly splintered femurs and airways full of blood, because a dramatic wound pulls attention even when it isn't the fastest killer. An obstructed airway ends a life in minutes. Tension pneumothorax takes longer, hemorrhage longer still, and head injury or hypothermia longer again. That is why the sequence orders itself by time to death, not by what looks worst. The primary survey hunts immediate threats to life and corrects them as they're found. A thorough head-to-toe exam means nothing if the client doesn't survive long enough to benefit from it. Question 9. A nurse finds an unresponsive client who collapsed while gardening with no suspicion of trauma. Which of the following maneuvers should the nurse use to open the airway? Your options are A. Head tilt, chin lift. B. Modified jaw thrust. C. Neck hyperextension. D. Neck flexion. Which one is it? Pause the video if you need more time. The correct answer is A. Head tilt, chin lift. A is correct because with no suspected trauma, the head tilt, chin lift is correct. Placing one hand on the forehead and lifting the chin moves the tongue away from the laryngopharynx and provides a patterned airway. B is wrong because the modified jaw thrust is reserved for clients with suspected traumatic neck injury because it maintains cervical spine alignment. With no trauma present, this maneuver is unnecessary and not the standard choice. C is wrong because hyperextending the neck can actually close the airway and cause injury rather than open it. This excessive motion is not a recognized airway technique and risks harming the client. D is wrong because flexing the neck does nothing to open the airway and can obstruct it by folding the chin toward the chest. The goal is to lift the tongue away, which flexion fails to accomplish. The head tilt, chin lift maneuver opens the airway by mechanically lifting the tongue off the back of the throat. In an unconscious person, muscle tone disappears, and a relaxed tongue simply falls backward against the pharynx. There's nothing stuck inside to remove, only an anatomic positional problem that needs a positional fix. One hand presses the forehead back while the fingers of the other lift the bony ridge of the chin, never the soft tissue underneath. Together, these motions extend the neck and pull the mandible forward. And since the tongue attaches to the mandible, it travels forward too, opening the pharynx. This is sometimes called the sniffing position, aligning the oral, pharyngeal, and tracheal axis into a straighter line. Exam writers test this concept through a trauma exception, because moving the neck in a spinal injury can turn a fracture into a cord injury. STEM signal that head tilt, chin lift is safe with phrases like unresponsive, collapsed, no trauma suspected, witness medical collapse, and snoring respirations. Meanwhile, a fall, a motor vehicle crash, a diving injury, or an unwitnessed collapse all point toward the jaw thrust instead, since the mechanism of injury is unclear or clearly traumatic. When mechanism is unknown, the safer assumption is always that trauma occurred. Head tilt, chin lift opens the airway more reliably and is easier to perform, but it moves the neck, while jaw thrust protects the spine but is harder to sustain. The phrase no suspicion of trauma isn't scene setting. It's the clinical permission that makes the tilt the right choice. Question 10. A nurse is caring for an unresponsive client who has a suspected cervical spine injury after a fall. Which of the following actions should the nurse take to open the airway? Your options are A. Perform a head tilt chin lift maneuver. B. Hyperextend the client's neck. C. Turn the head sharply to one side. D. Perform a modified jaw thrust maneuver. Take a second. Which answer would you pick? The correct answer is D. Perform a modified jaw thrust maneuver. D is correct because when trauma is suspected, the modified jaw thrust opens the airway while maintaining cervical spine alignment. The nurse lifts the jaw superiorly without moving the neck, protecting the spinal cord during the maneuver. A is wrong because the head tilt, chin lift, requires tilting the head and is contraindicated with possible cervical spine injury. Moving the neck this way could worsen a spinal injury, so it is avoided when trauma is suspected. B is wrong because hyperextending the neck applies dangerous motion to an unstable spine and can also close the airway. This action endangers the cord and does not safely establish a patterned airway in a trauma client. C is wrong because sharply turning the head rotates the cervical spine and could cause irreversible cord damage. Airway opening in trauma must keep the neck aligned, which forceful turning directly violates. Every airway maneuver solves the same problem, a relaxed tongue falling back and blocking the pharynx. The question is never whether to move the jaw forward. It's whether the head is allowed to move while doing it. The tongue is tethered to the mandible, so moving the jaw forward moves the tongue forward off the back of the throat. Head tilt, chin lift gets there by tipping the whole head back. Jaw thrust gets there by pushing the mandible forward from behind its angles, so the head never has to move. Here is the technique itself. The rescuer kneels at the head of the client, hooks fingers behind both mandibular angles, and thrusts the jaw forward and upward while the head stays perfectly neutral between the forearms. Jaw thrust is reserved for suspected cervical spine injury, signaled by a fall, a motor vehicle crash, a diving accident, or any unwitnessed collapse where a head or neck strike can't be ruled out. In these clients, extending the neck risks pushing an unstable fracture into the spinal cord and causing permanent quadriplegia. Jaw thrust isn't a gentler version of head tilt chin lift, it's anatomically different, translating the mandible forward while the skull and spine stay fixed together. If it fails to open the airway, the next step is an adjunct and escalation, not abandoning stabilization for a head tilt. Question 11. A nurse is performing a secondary survey and uses the Glasgow Coma scale to assess a client. Which of the following client responses does the scale evaluate? Your options are A. Pupil size and reaction to light. B. Pain location, quality and intensity. C. Eye opening, verbal and motor responses. D. Skin color, temperature and moisture. Before I reveal it, which one do you think is right? The correct answer is C. Eye opening, verbal and motor responses. C is correct because the Glasgow Coma scale rates a client's eye opening, verbal and motor responses to gauge level of consciousness. The nurse combines these category ratings to track changes in neurologic status over time. A is wrong because checking pupil size and the reaction to light is a separate part of the neurologic exam. It offers useful brainstem information but is not what this particular scoring tool was built to measure. B is wrong because assessing the character of pain belongs to a focused pain evaluation rather than a consciousness scale. Relying on it here would send the nurse gathering data this tool was never designed to capture. D is wrong because skin color, warmth, and moisture reflect circulation and perfusion instead of brain activity. Those findings reveal nothing about a client's level of consciousness, which is the entire focus of this assessment. The Glasgow Coma scale exists because words like stuporous, obtunded, and lethargic meant different things to different clinicians. 2 neurosurgeons in Glasgow replaced impressions with a reproducible number built from observable behaviors, so trend could finally be tracked across shifts. 3 categories are scored independently and summed: eye-opening, verbal response, and motor response. The total ranges from 3, meaning no response at all, to 15, meaning fully alert with obedience to commands. Each behavior taps a different depth of brain function. Eye-opening reflects arousal from the brainstem's reticular activating system. Verbal response reflects cortical language processing. And motor response tracks the pathway from cortex through brainstem to cord, making it the most sensitive measure. Pupils, vital signs, oxygen saturation, and reflexes are part of a full neurologic assessment, but none of them appear in the score. Pupillary changes signal brainstem compression from herniation, while the scale itself measures only the level of consciousness. If a client is intubated, the verbal component is marked untestable rather than scored as 1. A total score of 8 or less is the widely used threshold for a compromised airway, the origin of the teaching phrase about intubating below 9. Question 12. A nurse is assessing a client during the circulation step of the primary survey and suspects shock. Which of the following findings should the nurse expect? Your options are A. Decreased heart rate and hypertension, B. Increased urine output and warm skin, C. Bounding pulses and distended neck veins, D. Increased heart rate and hypertension. What's your answer? Commit to one before I continue. The correct answer is D. Increased heart rate and hypertension. D is correct because shock is the body's response to inadequate tissue perfusion and oxygenation. It manifests with an increased heart rate and hypotension and can progress to tissue ischemia and necrosis if uncorrected. A is wrong because a decreased heart rate with hypertension contradicts the compensatory picture of shock, where the heart speeds up and pressure falls. These opposite findings would not signal failing perfusion in this client. B is wrong because increased urine output and warm skin suggest adequate perfusion rather than shock. In poor circulation, the body shunts blood away from the skin and kidneys, producing the reverse of these reassuring signs. C is wrong because bounding pulses and distended neck veins point to fluid excess, not the diminished perfusion of shock. Shock instead produces a fast, weak pulse from low circulating volume and pressure. Shock means tissue perfusion has fallen below what cells need to survive. Understanding why the body reacts the way it does explains every finding on the exam and every finding at the bedside. Baroreceptors sense falling pressure and trigger sympathetic firing within seconds. Heart rate climbs to protect cardiac output while vessels constrict, shunting blood away from skin, gut, and kidneys toward the heart and brain. That shunting is exactly why skin turns cool and pale and urine output drops. This is the body buying time. It sacrifices skin, gut, and kidneys temporarily, so the heart and brain keep getting oxygen, which is why tachycardia appears first, and hypotension only shows up once that compensation finally fails. Exam writers exploit predictable mistakes. A slow heart rate in shock signals either neurogenic shock or terminal collapse, not simple slowing. Rising pressure with a slowing pulse points to increased intracranial pressure instead. And warm, flush skin belongs to early distributive shock while cold. Clammy skin marks hypovolemic shock, the kind trauma produces. Shock is an oxygen delivery problem, not just a volume problem, which is what separates it from simple dehydration. Watch the pulse, the skin, and the urine output long before the blood pressure ever drops. Question 13. A nurse is completing the exposure step of the primary survey on a trauma client. Which of the following actions should the nurse take to prevent hypothermia? Your options are A. Infuse warmed IV fluids, B. Apply cold compressors to the trunk, C. Open windows to circulate air, D. Remove all blankets from the client. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is A. Infuse warmed IV fluids. A is correct because infusing warmed IV fluids helps prevent hypothermia during exposure. Trauma clients lose heat from unwarmed oxygen and cold fluids, so warming infusions along with blankets preserves core temperature. B is wrong because applying cold compressors would lower body temperature and push the client toward the hypothermia the nurse is trying to prevent. Cooling measures are appropriate for heat stroke, not exposure-related heat loss. C is wrong because opening windows drops the surrounding temperature and increases heat loss. Safe care calls for raising the room temperature during exposure, so adding cold air directly contradicts it. D is wrong because removing blankets strips away insulation and accelerates cooling. Warm coverings are part of hypothermia prevention, so taking them away would worsen heat loss rather than protect the client. The exposure step of the primary survey does two things at once. It strips a trauma client to find hidden wounds, and it demands active measures to stop them from cooling in the process. Undressing a client to find wounds works, but combine it with cold intravenous fluids, chilled blood products, wet clothing, and an operating room kept cool for staff comfort, and resuscitation itself becomes a cooling process. Hypothermia disables clotting enzymes and platelets, worsening bleeding. Bleeding worsens hypoperfusion, driving acidosis, and acidosis further impairs clotting. Each piece accelerates the others, and once temperature drops below the mid-30s Celsius, mortality climbs no matter how well the surgery went. Prevention works best when it adds heat rather than just conserving it. Warmed IV fluids and blood products heat the core directly through circulation, while forced air blankets, radiant heaters, warmed rooms, warmed irrigation fluid, and removing wet clothing all add support. Students often confuse this with therapeutic hypothermia after cardiac arrest, where cooling protects the brain. In trauma, that same cooling destroys the clotting system, keeping a bleeding client alive. So the direction of the intervention depends entirely on whether hemorrhage is present. Question 14. A nurse is caring for 4 clients and must decide which one warrants notifying the rapid response team for a rapid decline. Which of the following clients should the nurse prioritize for the team? Your options are A. High glucose with a heel injury. B. Bleeding on a femoral dressing. C. Dark red toes, absent pedal pulse. D. Calf pain with shortness of breath. Which would you go with? Lock it in before the reveal. The correct answer is D. Calf pain with shortness of breath. D is correct because right calf pain with shortness of breath signals a possible embolism and risk for respiratory arrest, the kind of rapid decline the rapid response team exists to catch before arrest occurs. A is wrong because a high glucose level with a heel pressure injury is concerning, but reflects an ongoing problem the provider should address. It does not represent the sudden deterioration toward arrest that activates the team. B is wrong because bleeding on a femoral dressing needs the provider's attention and possible reinforcement. Yet it is a localized issue. This finding lacks the airway or cardiovascular collapse warning that defines a rapid decline. C is wrong because dark red toes with an absent pedal pulse indicate compromised circulation to the limb that the provider must evaluate. Although serious, it threatens the extremity rather than signaling imminent respiratory or cardiac crisis. Rapid response teams exist because most cardiac arrests on general units are not sudden. Researchers found that in most cases, abnormal vitals, new confusion, or breathing changes were documented for 6 to 8 hours before the arrest, but nobody escalated care. Activation criteria are deliberately broad. An abnormal heart or respiratory rate, low blood pressure, falling oxygen, a drop in consciousness, seizure, or chest pain. Nearly every hospital also includes a purely judgment-based criterion, because experienced nurses often sense deterioration before it appears in the numbers. Cough pain with shortness of breath earns immediate escalation because the two findings tell one story. Unilateral cough pain suggests a clot in the leg. Sudden dyspnea suggests that clot has traveled to the lungs as a pulmonary embolism, which can kill quickly and has a short treatment window. The real skill being tested is prioritization. A finding present for days and unchanged is not a rapid decline, but a new finding, or a combination pointing to a specific life-threatening process is. The question is really asking which client is most likely to arrest within the hour. A code team responds after an arrest to resuscitate. A rapid response team acts before the arrest to prevent it. Calling early and being wrong costs far less than calling late and being right. Question 15. A nurse is caring for a client who arrived in the emergency department after ingesting a toxic agent. Which of the following actions should the nurse take? Your options are administer syrup of ipecac. B. Induce vomiting manually. C. Instill activated charcoal. D. Withhold all IV fluids. Don't overthink it. Which one feels right? The correct answer is C. Instill activated charcoal. C is correct because activated charcoal adsorbs toxins and does not enter the bloodstream, making it an appropriate measure for an ingested poison. It binds the agent within the gut to limit further absorption. A is wrong because syrup of ipecac is no longer recommended because inducing emesis increases the risk of aspiration. This agent is no longer recommended for poison management, so giving it would be unsafe. B is wrong because manually inducing vomiting raises the danger of aspirating gastric contents into the lungs. Current management avoids emesis entirely, relying instead on adsorption and lavage to remove the toxin safely. D is wrong because withholding IV fluids removes a key intervention, since fluids dilute toxins and promote renal elimination. Restoring fluids supports the kidneys, so denying them works against clearing the poison. Activated charcoal treats poisoning by adsorption, binding toxin molecules onto its surface inside the gut so they leave in the stool instead of entering the bloodstream. Steam and chemical processing rip open a massive network of pores, giving one dose a surface area of thousands of square meters. Charcoal replaced syrup of ipecac and gastric lavage, both abandoned because studies showed they removed little toxin while causing real harm. Ipecac caused prolonged vomiting that delayed care and risked aspiration, and lavage risked esophageal injury for a modest return. Charcoal survived because it avoids both problems. The mechanism sets its own limits. Charcoal fails against small charged particles like lithium, iron, alcohols, and strong acids or alkalis, and it only works within about an hour of ingestion. It is also contraindicated with decreased consciousness or absent gag reflex unless the airway is protected, after corrosive ingestion, and with bowel obstruction or perforation. Picture the mechanism in the gut wall itself. Charcoal's porous surface grabs toxin molecules and holds them in place, preventing them from crossing into the bloodstream, so they pass out harmlessly in the stool instead. Charcoal is nonspecific, working in the gut lumen to stop absorption of whatever remains. Antidotes like acetylcysteine, naloxone, and flumazenil are specific, acting on toxin already circulating in the blood. A serious poisoning often needs both, not one instead of the other. Question 16. A nurse is assessing a client who collapsed outdoors during extreme heat and suspects heat stroke. Which of the following findings should the nurse expect? Your options are A. Lack of perspiration with altered mental status. B. Profuse sweating with a normal temperature. C. Low heart rate with increased urine output. D. Cool moist skin with hypertension. Got a guess? Lock it in. The correct answer is A. Lack of perspiration with altered mental status. A is correct because heat stroke produces a lack of perspiration, an elevated temperature, and alterations in mental status. The failure to sweat distinguishes this medical emergency, which requires immediate treatment to prevent death. B is wrong because profuse sweating with a normal temperature describes heat exhaustion rather than heat stroke. Heat stroke is marked by the loss of the ability to perspire, and a dangerously high temperature not preserves sweating. C is wrong because heat stroke raises the heart rate and decreases urine output. So a low pulse with increased output contradicts the expected picture. These findings would point away from the failing thermoregulation of heat stroke. D is wrong because cool, moist skin with hypertension opposes heat stroke, which causes hot, dry skin and low blood pressure. The hallmark is absent perspiration and hypotension, the reverse of these described findings. Heat stroke is the most severe heat illness, defined by a core temperature above roughly 104 degrees combined with central nervous system dysfunction, confusion, seizure or coma alongside dangerously high temperature is what identifies it, and the classic clue is hot, dry skin, because sweating has stopped. The body normally sheds heat through radiation, conduction, convection, and evaporation. And evaporation of sweat does nearly all the work in a hot environment. As heat stress continues, plasma volume drops and the hypothalamic thermoregulatory center becomes overwhelmed and fails. Sweat production stops. The last cooling mechanism switches off and core temperature climbs without a break. Heat cramps bring painful spasms with normal temperature and clear thinking. Heat exhaustion brings heavy sweating, weakness, and cool, clammy skin, with temperature elevated but mental status preserved. Heat stroke is the point where thermoregulation fails outright. Sweating stops, temperature spikes, and cellular proteins denature, leading to multi-organ failure. The nuance tested is the transition from profuse sweating to no sweating at all. A hotter person sweating harder describes heat exhaustion, not heat stroke. Dry skin with confusion is the true emergency. Though in young athletes with exertional heat stroke, skin can still be moist. So mental status carries more diagnostic weight than skin alone. Treatment follows the mechanism: rapid cooling with ice packs, evaporative misting, and cooled IV fluids takes priority, since antipyretics do nothing for a failed thermostat. Remember, temperature alone is not enough. It's failed thermoregulation, shown by dry skin and dangerously high temperature, together with a malfunctioning brain, that defines this minute matter emergency. Question 17. A nurse is caring for a client who fell through ice and is hypothermic, unresponsive, and breathing slowly. Which of the following actions should the nurse take? Your options are: A. Maintain a normal room temperature. B. Apply cool cloths to the skin. C. Infuse warmed IV fluids. D. Encourage the client to drink iced water. Which one is it? Pause the video if you need more time. The correct answer is C. Infuse warmed IV fluids. C is correct because infusing warmed IV fluids raises body temperature and preserves tissue in a hypothermic client. Combined with removing wet clothing and applying warm blankets, this directly counters the dangerous heat loss. A is wrong because keeping the room at a normal temperature is insufficient, because the room temperature should be increased to help warm the client. Settling for a normal setting fails to actively reverse the hypothermia. B is wrong because applying cool cloths would further lower core temperature and deepen the hypothermia. The client needs warming measures, so cooling the skin directly opposes the goal of restoring body heat. D is wrong because offering iced water adds cold to the body and is also unsafe in an unresponsive client who could aspirate. Warming interventions, not cold intake, are required to treat hypothermia. Hypothermia is graded by severity, and that grade determines exactly how a client is rewarmed. Get the order wrong and the very act of warming someone up can stop their heart. Mild hypothermia causes shivering, confusion, and clumsiness. Moderate hypothermia stops the shivering and slows the pulse and breathing. Severe hypothermia brings unresponsiveness, profound bradycardia, and a heart so irritable it can slip into a lethal rhythm at any moment. Passive rewarming just removes wet clothing and lets an intact shivering response do the work. Active external rewarming adds heat to the skin surface. Active internal or core rewarming delivers heat to the inside of the body through warmed fluids, warmed oxygen, and warmed lavage. And it's the method reserved for severe cases. Here's the danger. Warming the skin first dilates peripheral vessels, sending cold, acidotic blood that's been pooling in the arms and legs rushing back toward the heart. Core temperature actually drops further, a phenomenon called afterdrop, and that acid load can trigger ventricular fibrillation in an already irritable heart. Cold slows the brain's metabolic demand, which is why resuscitation continues so much longer in a cold client than a warm one. Handle these clients gently. Avoid rubbing cold limbs, warm the core first. And remember, a hypothermic client is not dead until warm and dead. Question 18. A nurse is assisting with resuscitation of a client who is in a systole. Which of the following actions should the nurse anticipate? Your options are A. Delivering immediate defibrillation. B. Administering a full epinephrine. C. Initiating transcutaneous pacing. D. Elevating the client's lower extremities. Take a second. Which answer would you pick? The correct answer is B. Administering IV epinephrine. B is correct because during asystole, the nurse anticipates administering IV epinephrine, which increases heart rate, improves cardiac output, and promotes bronchodilation. Epinephrine is repeated at regular intervals per ACLS protocol. A is wrong because defibrillation is not indicated for a systole because it is not a shockable rhythm. Shock therapy targets ventricular fibrillation or pulsus ventricular tachycardia, not the absent electrical activity in a systole. C is wrong because transcutaneous pacing is not indicated for asystole within this resuscitation protocol. Care for this rhythm centers on epinephrine and CPR rather than pacing, which is reserved for certain symptomatic bradycardias instead. D is wrong because elevating the lower extremities is an intervention for shock, where it shunts blood to vital organs. In asystole, the priority is CPR and epinephrine, so leg elevation does not address the arrest. Asystole is the complete absence of ventricular electrical activity, showing as a flat or nearly flat line on the monitor. There's no organized rhythm, no contraction, and no cardiac output, and it carries the worst prognosis of any arrest rhythm. Defibrillation depolarizes the whole heart at once to interrupt a chaotic rhythm so the natural pacemaker can take back over. A systole has no electrical activity to reorganize, so a shock does nothing. It only interrupts the compressions that are actually perfusing the brain. Management rests on high-quality compressions. Epinephrine every 3 to 5 minutes to boost aortic diastolic pressure through vasoconstriction, and a relentless search for reversible causes, because asystole almost never resolves on its own. The reversible causes span hypovolemia, hypoxia, acidosis, abnormal potassium hypothermia, tension pneumothorax, tamponade, toxins, and thrombosis. Correcting the cause is often the only path back to circulation, so this search runs alongside compressions, never after them. Asystole and pulseless electrical activity share the same non-shockable treatment path of compressions, epinephrine, and cause finding, but asystole shows nothing on the monitor, while PEA shows an organized rhythm without a pulse. Confirm the flat line in a second lead before you believe it, and never reach for the paddles. Question 19. A nurse is monitoring a client on a cardiac unit who suddenly develops ventricular fibrillation. Which of the following interventions should the nurse anticipate for this client? Your options are A. Oral antidysrhythmic medication. B. Elevating the lower extremities. C. Immediate defibrillation. D. Withholding chest compressions. Before I reveal it, which one do you think is right? The correct answer is C. Immediate defibrillation. C is correct because ventricular fibrillation causes loss of consciousness, pulselessness, and no breathing, and it requires immediate defibrillation using ACLS protocol. Prompt electrical therapy is the key intervention for the shockable rhythm. A is wrong because an oral antidysrhythmic cannot work fast enough and is inappropriate in arrest. Emergency catecholamines are given IV, not by mouth, because the oral route is far too slow for a pulseless rhythm. B is wrong because elevating the legs is a measure for shock, not for a lethal rhythm. Ventricular fibrillation demands immediate defibrillation and CPR, so repositioning the extremities would only waste precious time during a life-threatening pulseless emergency. D is wrong because withholding chest compressions would abandon the CPR that sustains perfusion until and after a shock. Compressions are central to managing ventricular fibrillation, so stopping them endangers the client. Ventricular fibrillation is an electrical storm in the ventricles. Many sites fire independently. No coordinated contraction happens, and the heart quivers instead of pumping. Cardiac output drops to zero instantly, and the client becomes pulseless within seconds. The urgency is not rhetorical. Survival falls by roughly 7 to 10% for every minute that passes before the first shock. Compressions keep blood moving, but never correct the underlying rhythm, and as time passes without perfusion, the fibrillation coarsens and eventually turns into a systola. The shock depolarizes the entire myocardium at once, silencing all the competing electrical activities simultaneously. From that brief silence, the sinoatrial node, the heart's fastest natural pacemaker, can take back control and restore an organized rhythm, but only while the muscle still has energy stores left to respond. The key distinction exam writers test is timing. Cardioversion synchronizes to the R wave to avoid the vulnerable T wave, and it treats organized rhythms with a pulse. Defibrillation is unsynchronized because there is no R wave to sync with in VFib, and ultimately the pulse check, not the rhythm name alone, determines which treatment is given. Compressions continue while the defibrillator charges and resume immediately after the shock, and medications like epinephrine and amiodarone follow later shocks, never the first. When a rhythm is pulseless and chaotic, the treatment is immediate. Unsynchronized defibrillation, no exceptions. Question 20. A nurse is assessing a client who has fluid volume deficit from prolonged vomiting. Which of the following findings should the nurse expect to observe? Your options are A. Bounding pulse and crackles. B. Tachycardia and poor skin turgor. C. Distended neck veins and edema. D. Hypertension and weight gain. What's your answer? Commit to one before I continue. The correct answer is B. Tachycardia and poor skin turgor. B is correct because fluid volume deficit produces tachycardia as the body works to maintain blood pressure, along with poor skin turgor from reduced tissue fluid. These signs reflect decreased circulating volume. A is wrong because a bounding pulse and crackles indicate fluid excess, where extra volume strengthens the pulse and backs up into the lungs. These findings are the opposite of the diminished volume seen in deficit. C is wrong because distended neck veins and edema reflect fluid overload as excess fluid fills the vessels and tissues. In deficit, the neck veins flatten and turgor declines, so these signs point to the wrong imbalance. D is wrong because hypertension and weight gain occur with fluid excess, not deficit. A client low on volume shows hypertension and acute weight loss, making elevated pressure and added weight inconsistent with the deficit. Fluid volume deficit is a loss of water and electrolytes together in roughly equal proportion, so the volume shrinks but concentration stays normal. That's different from pure dehydration, where water alone is lost and sodium rises. Every vascular finding follows from less fluid returning to the heart. Smaller volume means smaller stroke volume, so the body raises heart rate first, producing tachycardia. Blood pressure falls, pulses turn weak and thready, and urine output drops as the kidneys hold onto everything they can. Volume deficit and volume excess produce mirror image findings, which is exactly what exam writers test. Deficit gives tachycardia, hypertension, weak pulses, flat neck veins, poor skin turgor, dry membranes, and weight loss. Excess gives bounding pulses, hypertension, distended neck veins, crackles, edema, and weight gain. Outside the blood vessels, tissue itself loses water. Skin turgor decreases, so a pinched fold flattens slowly instead of snapping back. Mucous membranes dry out, the tongue furrows, and eyes look sunken. Weight is the single most reliable measure of fluid change, since a liter of fluid weighs about 1 kilogram. Skin turgor loses reliability in older adults, so it's a supporting finding, not a definitive one. Next to daily weight and intake and output, left uncorrected, fluid volume deficit progresses to hypovolemic shock, where compensation fails and perfusion becomes inadequate. Question 21. A nurse is caring for a client who has fluid volume excess related to heart failure. Which of the following findings should the nurse expect to observe? Your options are A. Dyspnea and peripheral edema, B. Sunken eyeballs and oliguria, C. Thready pulse and thirst, D. Flattened neck veins and dry tongue. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is A. Dyspnea and peripheral edema. A is correct because fluid volume excess causes dyspnea as fluid backs into the lungs, and peripheral edema as excess fluid collects in tissues. Crackles, weight gain, and distended neck veins also accompany this overload. B is wrong because sunken eyeballs and oliguria are classic deficit findings caused by low fluid volume. In excess, the body holds extra fluid, so these signs of dehydration contradict the overloaded state. C is wrong because A. Thready pulse and thirst signal deficit, where shrinking volume weakens the pulse and triggers thirst. Excess instead produces a strong bounding pulse, making these findings inconsistent with overload. D is wrong because flattened neck veins and a dry tongue reflect inadequate volume. Fluid excess distends the neck veins and moistens tissues, so these dehydration signs belong to deficit rather than overload. Fluid volume excess means the extracellular compartment expands because water and sodium are retained together, so volume rises while concentration stays roughly normal. Heart failure, kidney failure, cirrhosis, excess IV fluids, and corticosteroids all cause it, and the extra fluid splits between the vascular space and the interstitial space. When the left ventricle fails, blood backs up into the lungs, hydrostatic pressure rises, and fluid leaks into the alveoli, causing crackles and dyspnea that worsen when lying flat. When the right ventricle fails, pressure backs up into the systemic veins instead, producing distended neck veins and enlarged liver, and pitting edema in the ankles or sacrum. Excess and deficit are mirror images, which is exactly why students reverse them. Excess produces bounding pulses, hypertension, distended neck veins, crackles, edema, and weight gain, while deficit produces thready pulses, hypotension, flat neck veins, poor skin turgor, and dry mucous membranes. Pitting edema confirms fluid has moved into tissue, but a person can retain several liters of excess fluid before any swelling becomes visible. That's why daily weight and lung sounds are more sensitive warning signs than simply looking at the ankles. Swelling in one leg with clear lungs and stable weight points to a local problem like venous insufficiency. Swelling in both legs together with crackles orthopnea, and rapid weight gain is the signature of whole body fluid volume excess. Question 22. A nurse is caring for a weak, confused client who is dizzy on standing and has a fever with borderline blood pressure from dehydration. Which of the following actions should the nurse take? Your options are: A. Restrict the client's oral fluids. B. Encourage independent ambulation. C. Monitor for orthostatic hypotension. D. Withhold a full fluid therapy. Which would you go with? Lock it in before the reveal. The correct answer is C. Monitor for orthostatic hypotension. C is correct because with dizziness on standing and borderline pressure, the nurse should monitor for orthostatic hypotension, offer fluids, and keep the client in bed because the dehydration creates a real fall risk. A is wrong because restricting fluids worsens dehydration when the client actually needs rehydration. Limiting intake would deepen the volume loss, driving the low pressure and confusion, moving care in the wrong direction. B is wrong because encouraging independent ambulation ignores the fall risk created by dizziness and orthostatic changes. A dehydrated, confused client should be kept safe in bed rather than pushed to walk alone. D is wrong because withholding a free fluid therapy denies one of the main treatments for dehydration. Oral or IV rehydration restores the lost volume. So refusing fluids leaves the underlying deficit and its troubling symptoms completely uncorrected. Orthostatic hypotension is a drop in blood pressure that happens when someone moves from lying to sitting or sitting to standing. The threshold is a systolic fall of at least 20 millimeters of mercury, or a diastolic fall of at least 10, within 3 minutes of that position change. The phenomenon exists because gravity moves blood. Standing shifts several hundred milliliters into the veins of the legs and abdomen almost instantly. So less blood returns to the heart, stroke volume drops and pressure falls. In a healthy person, baroreceptors detect the fall within a heartbeat or two and trigger vasoconstriction and a faster heart rate that restores pressure before symptoms appear. This compensation is fast and automatic, but it is also easy to overwhelm. Volume depletion overwhelms the reflex directly, leaving less blood to redistribute. Fever worsens it through fluid loss and vasodilation and age, prolonged bed rest, antihypertensive medications, diuretics, and diabetic autonomic neuropathy all blunt the response further. Clinically, this matters because dizziness on standing is the moment of highest fall risk in a client's day. Monitoring for orthostatic changes turns a vague complaint into a measurable finding, guiding safe interventions rather than aggressive ones like restricting fluids or rushing ambulation. Question 23. A nurse is caring for a client whose fluid volume deficit has progressed to hypovolemic shock. Which of the following actions should the nurse take first? Your options are: A. Administer oxygen. B. Obtain a daily weight. C. Apply antiembolism stockings. D. Provide a sodium-restricted diet. Don't overthink it. Which one feels right? The correct answer is A. Administer oxygen. A is correct because in hypovolemic shock, oxygen delivery to the tissues drops sharply. So administering oxygen is the priority to support oxygenation while fluid replacement and other measures follow close behind. B is wrong because obtaining a daily weight tracks fluid status over time, but does nothing for the immediate perfusion crisis. During active shock, the client needs oxygen and volume, not a routine monitoring task. C is wrong because antiembolism stockings address clot prevention, an issue unrelated to the failing perfusion of shock. They do not restore oxygen delivery, so applying them would not meet the urgent need. D is wrong because a sodium-restricted diet is a measure for fluid excess, the opposite of this client's problem. Restricting sodium offers no help in a deficit emergency that calls for oxygen and fluids. Hypovolemic shock is what happens when compensation fails and cells stop getting enough oxygen. Blood pressure drops, mental status changes, skin turns cold and clammy, and urine output nearly stops. The critical insight is that shock is not fundamentally a blood pressure problem. It's a failure of oxygen delivery. Oxygen delivery depends on three things multiplied together: the amount of hemoglobin available, how saturated that hemoglobin is with oxygen, and cardiac output. Fluid resuscitation restores cardiac output, but it takes time to get access and infuse enough volume to matter. Supplemental oxygen works within seconds, needs no access, and maximizes the oxygen carried by whatever blood is still circulating. In the interval between recognizing shock and delivering meaningful fluid volume, oxygen is what keeps the brain and heart supplied. The framework is the same one that governs every emergency: airway, breathing, circulation. Oxygenation comes before volume replacement in the sequence of actions, even though both interventions run together within a minute of each other. Don't confuse this with uncomplicated fluid volume deficit, where fluid genuinely is the leading intervention because perfusion hasn't failed yet. Deficit is a volume problem corrected with volume. Shock is an oxygen delivery problem, and oxygen leads. Question 24. A nurse is caring for a client with fluid volume excess who develops pulmonary edema. Which of the following findings should the nurse expect? Your options are A. Sunken eyeballs, B. Poor skin turgor, C. Flattened neck veins, D. Frothy pink tinged sputum. Got a guess? Lock it in. The correct answer is D. Frothy pink tinged sputum. D is correct because pulmonary edema produces frothy pink tinged sputum along with ascending crackles and dyspnea at rest as fluid floods the alveoli. This finding signals a serious complication of fluid overload. I is wrong because sunken eyeballs are a sign of fluid deficit, not the overload that causes pulmonary edema. This dehydration finding would not appear in a client whose lungs are filling with excess fluid. B is wrong because poor skin turgor reflects low fluid volume and dehydration. Pulmonary edema arises from too much fluid, so diminished turgor points to the opposite imbalance and would not be expected here. C is wrong because flattened neck veins appear when the circulating volume is low rather than high. In fluid overload, the neck veins distend with the extra volume, so flat veins directly contradict the excess state that produces pulmonary edema. Pulmonary edema is fluid flooding the alveoli and interstitial tissue of the lungs, and it is the most immediately life-threatening form of fluid volume excess. Since the alveoli are where oxygen and blood are supposed to meet, filling them with fluid means the client is effectively drowning in fluid made by their own circulation. The mechanism runs through pressure. A failing left ventricle backs pressure up through the left atrium into the pulmonary capillaries, and once that hydrostatic pressure overwhelms the oncotic pressure holding fluid inside the vessels, plasma and even red blood cells get pushed across the alveolar membrane, first into the interstitium and then into the alveoli themselves. The hallmark finding, frothy pink sputum, comes directly from that mechanism. The froth is created by air being forced through fluid with each breath, and the pink tinge comes from red blood cells that cross the damaged membrane alongside the plasma, making it a nearly specific sign that fluid has reached the alveolar space. Exam writers test whether you can separate this from other causes of breathlessness. Pneumonia brings purulent sputum and fever. Pulmonary embolism brings sudden dyspnea with clear lungs. And asthma or COPD bring wheezing, while ARDS floods the alveoli too, but through membrane injury rather than pressure, so it won't respond to diuretics the way cardiogenic edema does. Frothy pink sputum belongs to none of the mimics, which makes it the highest value single finding in this entire content area. Question 25. A nurse is reinforcing teaching with a client who has fluid volume excess. Which of the following statements should the nurse include? Your options are A. Drink all fluids each morning. B. Add extra salt to your meals. C. Report a sudden weight gain promptly. D. Lie flat throughout the day to rest. Which one is it? Pause the video if you need more time. The correct answer is C. Report a sudden weight gain promptly. C is correct because clients who have fluid excess should weigh themselves daily at the same time each morning and report any sudden weight gain, since a rapid rise reflects retained fluid that needs prompt attention. A is wrong because drinking all fluids in the morning ignores the instruction to divide the daily fluid allotment across the day. Front-loading intake could overload the client and does not match the prescribed restriction. B is wrong because adding salt directly opposes the sodium-restricted diet these clients need. Extra sodium pulls water into the vascular space and worsens fluid retention, making this advice harmful for overload. D is wrong because lying flat all day works against positioning for fluid excess, which favors semi or high fouls to ease breathing. A flat position can increase respiratory effort when fluid is overloaded. Daily weight is the single most reliable indicator of fluid status you have at home, and it's why teaching a heart failure client to weigh themselves daily is such a high-value intervention. The math is simple. 1 liter of retained fluid weighs about 1 kilogram, a little over 2 pounds. Body tissue can't change that fast, so any quick weight shift is fluid, and the scale catches it before ankles swell or lungs crackle. For the number to mean anything, the client weighs at the same time each morning, after urinating and before eating or drinking in similar clothing on the same scale. The commonly taught reporting thresholds are a gain of 2 to 3 pounds in a day or 5 pounds in a week. A client can retain several liters of fluid before edema appears in the ankles or crackles appear in the lungs, but the scale is already moving during that silent accumulation, which is exactly when a diuretic adjustment at home can prevent a hospital admission. Clients often assume feeling well means they can relax the regimen, but heart failure management is maintenance, and no symptom usually means the plan is working, not that the condition resolved. Weight captures what intake and output logs miss, which is why the scale outperforms the log at home. Question 26. A nurse is assessing a client who has hyponatremia following prolonged diuretic therapy. Which of the following findings should the nurse expect? Your options are A. Intense thirst and high fever. B. Dry mucous membranes and restlessness. C. Increased deep tendon reflexes. D. Confusion and muscle weakness. Take a second. Which answer would you pick? The correct answer is D. Confusion and muscle weakness. D is correct because hyponatremia causes water to shift into cells, producing cellular edema with confusion, headache, decreased reflexes, and muscle weakness. Severe cases can progress to seizures from the swelling of brain cells. A is wrong because intense thirst and high fever belong to hyponatremia, where water leaves the cells and dehydrates them. These findings reflect a high sodium level rather than the low sodium of hyponatremia. B is wrong because dry mucous membranes and restlessness are features of hyponatremia and cellular dehydration. In hyponatremia, cells take on water, so these signs of a fluid-depleted state point to the opposite imbalance. C is wrong because increased deep tendon reflexes accompany hyponatremia, whereas hyponatremia tends to lower the reflexes instead. The depressed neuromuscular response that comes with a low sodium level makes brisk. Exaggerated reflexes inconsistent with this particular finding. Hyponatremia means serum sodium below about 135 milliequivalents per liter, because sodium is the main solute outside cells. A falling sodium level is really a falling osmolality, and everything that follows stems from that shift. Water always moves toward the higher concentration of solute. When sodium outside the cell drops, water rushes inward and cells swell, and the brain, locked inside a rigid skull, suffers the most from this swelling. Every cell in the body swells with low sodium, but only the brain is trapped inside a rigid box. That confinement is why the earliest and most prominent findings of hyponatremia are neurologic rather than muscular or gastrointestinal. Both low and high sodium cause confusion, so exams separate them by muscle and mucous membrane findings. Low sodium brings weakness, sluggish reflexes, and normal or moist membranes, while high sodium brings thirst, dry, sticky membranes, restlessness, and often brisker reflexes. Sodium must be corrected slowly, since rapid correction pulls water out of adapted brain cells and risks irreversible osmotic demyelination. Remember, a weak, sluggish, confused patient without thirst signals too little sodium, not too much. Question 27. A nurse is planning care for a client who has hyponatremia from water deprivation. Which of the following interventions should the nurse include in the plan? Your options are: A. Encourage water intake and restrict sodium. B. Administer hypertonic saline rapidly. C. Provide high sodium foods. D. Limit the client's free water intake. Before I reveal it, which one do you think is right? The correct answer is A. Encourage water intake and restrict sodium. That is correct because care for hyponatremia includes encouraging water and restricting sodium to dilute the elevated level. Often with loop diuretics, seizure precautions are also maintained because high sodium can cause seizures and coma. B is wrong because rapidly giving hypertonic saline would raise sodium further and worsen the imbalance. Hypertonic saline is reserved for severe hyponatremia and is infused slowly, making it inappropriate for an already high level. C is wrong because providing high sodium foods adds the very electrolyte that is already elevated. The plan calls for sodium restriction, so increasing dietary sodium would deepen the hyponatremia rather than correct it. D is wrong because limiting free water deprives the client of the dilution needed to lower sodium. Because water follows sodium, encouraging fluids helps restore balance, so restricting water moves care in the wrong direction. Hyponatremia means serum sodium above about 145 milliequivalents per liter, and almost always it's a water problem, not a salt problem. The body has lost too much water or hasn't taken in enough to keep up, because thirst is normally such a powerful regulator that sodium intake alone rarely causes this. Hyponatremia happens almost exclusively in people who can't get water or can't perceive thirst, older adults with dementia, sedated or unconscious clients, infants, and clients with restricted mobility. In a hospital or care facility, this is often a nursing failure rather than a disease process. The physiology is the reverse of low sodium. Fluid outside the cells becomes concentrated, so water moves out of cells and they shrink. When brain cells shrink inside the skull, it produces restlessness, agitation, muscle twitching, hyperreflexia, and in severe cases seizures, coma, and even torn bridging veins with bleeding. Treatment replaces the water deficit directly, with oral water as the safest first step, limited dietary sodium, and hypertonic IV fluid when swallowing isn't possible. Brain cells have adapted to the high osmolality environment, so correcting sodium too fast lets water rush in and cause cerebral edema and seizures. Correction must be gradual, and isotonic saline should be avoided since it adds more sodium. Don't confuse this with fluid volume deficit, that loses water and sodium proportionally, keeping concentration normal, while hyponatremia loses water disproportionately, driving concentration up. One is treated with isotonic fluid, the other with water given slowly. Question 28. A nurse is reviewing the record of a client who received 3 tap water enemas and now has a low sodium and low potassium level. Which of the following does the nurse identify as the cause? Your options are A. Isotonic full fluid administration, B. Routine antibiotic therapy, C. A high sodium meal plan, D. Tap water enemas diluting electrolytes. What's your answer? Commit to one before I continue. The correct answer is D. Tap water enemas diluting electrolytes. D is correct because tap water is hypertonic and the GI losses from enemas are isotonic. So repeated tap water enemas dilute the blood and flush out electrolytes, producing the low sodium and potassium described. A is wrong because isotonic V fluids match the body's tonicity and would not dilute the blood or cause this drop. Because they do not lower electrolytes, they cannot explain the low sodium and potassium values. B is wrong because routine antibiotics do not characteristically deplete sodium and potassium through this mechanism. The imbalance here arises from the enemas, not from antibiotic therapy, which targets infection instead. C is wrong because a high sodium meal plan would tend to raise sodium rather than lower it. This intake works against the observed hyponatremia, so it cannot be the source of the depleted electrolytes. Repeated tap water enemas can cause a dangerous drop in sodium and potassium, not by removing electrolytes, but by drowning them in extra water. Tap water is hypertonic, almost free of sodium and potassium, so when it crosses the absorptive colon wall, it dilutes the body's existing electrolytes, even though the total amounts haven't changed. Water is pulled across the colon wall into the bloodstream because the fluid inside is hypertonic, while potassium moves the opposite way into the lumen. So dilution and loss happen together, and the electrolyte drop can be steep. The result is water intoxication. Falling sodium causes brain swelling, confusion, and seizures, while falling potassium causes muscle weakness, diminished reflexes, and dangerous cardiac irritability. Unlike diarrhea, which depletes fluid and electrolytes together, repeated tap water enemas add fluid. So the real signal is low sodium and low potassium appearing alongside signs of fluid excess, not fluid loss. Question 29. A nurse is caring for a client who has an elevated potassium level. Which of the following assessments should the nurse prioritize? Your options are A. Polyuria and increased thirst, B. Cardiac rhythm on the ECG, C. Frequency of constipation, D. Fine tremors of the hands. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is B. Cardiac rhythm on the ECG. B is correct because hyperkalemia raises the risk of dangerous dysrhythmias. So the nurse prioritizes assessing the cardiac rhythm. Peaked T waves and a widened QRS can progress to life-threatening rhythms or asystole. A is wrong because polyuria and thirst are not the hallmark of high potassium, and hyperkalemia tends to cause oliguria instead. These findings do not capture the cardiac danger that makes rhythm the priority assessment. C is wrong because constipation reflects hypokalemia, where slowed bowel activity occurs, rather than hyperkalemia, which often brings hyperactive bowel sounds and diarrhea. Focusing on the bowel pattern here would miss the urgent cardiac concern that dominates high potassium. D is wrong because hand tremors are not a defining feature of hyperkalemia and do not signal its most lethal threat. The peaked T waves and rhythm changes of high potassium make cardiac monitoring far more important. Hyperkalemia means a serum potassium above about 5.0 milliequivalents per liter. Potassium is the dominant cation inside cells, and the gradient across the cell membrane sets the resting membrane potential of every excitable cell. So even small shifts in the blood level change how easily those cells fire. The heart is what matters most because its tolerance is so narrow. As extracellular potassium rises, the resting membrane potential becomes less negative. Cells inch closer to threshold, and then sodium channels inactivate, slowing conduction until the rhythm can degenerate into ventricular fibrillation or asystole. The electrocardiogram changes in a recognizable order. Tall peaked T waves appear first, then the PR interval lengthens and the P wave flattens and vanishes, then the QRS widens, and a widened QRS merging with the T wave produces the sine wave pattern that precedes arrest. These changes can appear before the client reports any symptoms. Causes cluster into three groups: reduced excretion from kidney failure, potassium-sparing diuretics, or ACE inhibitors and ARBs, shift out of cells from acidosis, diabetic ketoacidosis, or tissue breakdown like crush injury and burns, and increased intake, which mostly matters when the client cannot excrete potassium, as with dialysis. Muscle weakness, paresthesias, and gastrointestinal symptoms are real, but none predicts how close a client is to an arrhythmia, which is why the monitor always outranks them. Remember the contrast. High potassium peaks the T wave, while low potassium flattens it and raises a U wave. Question 30. A nurse is caring for a client who has a high potassium level with ECG changes. Which of the following medications should the nurse anticipate administering for cardiac protection? Your options are A. Potassium chloride, B. A potassium-sparing diuretic, C. A salt substitute, D. Calcium gluconate. Which would you go with? Lock it in before the reveal. The correct answer is D. Calcium gluconate. D is correct because calcium gluconate provides cardiac protection in hyperkalemia by stabilizing the myocardium against dysrhythmias. Insulin with dextrose or sodium bicarbonate may also be used to shift potassium back into the cells. A is wrong because potassium chloride would add more potassium to an already dangerous level. Giving it would intensify the hyperkalemia and its cardiac threat, the exact opposite of the protection the client requires. B is wrong because a potassium-sparing diuretic causes the body to retain potassium and is actually a cause of hyperkalemia. Using it here would worsen the elevation rather than protect the heart from rhythm disturbances. C is wrong because salt substitutes are high in potassium and contribute to hyperkalemia. Rather than safeguarding the heart, this choice would raise the potassium level and heighten the risk of dysrhythmias. Calcium gluconate is given in hyperkalemia not to lower the potassium but to protect the heart from it. It is one of the few urgent treatments that leaves the underlying lab value completely unchanged, and understanding that distinction is the whole point of this topic. Rising potassium pushes the resting membrane potential up toward threshold, narrowing the gap that keeps heart cells electrically stable and eventually shutting down sodium channels. Calcium works differently. It raises the threshold potential itself, restoring that gap. Conduction stabilizes, and the risk of a lethal rhythm falls, all while the serum potassium stays exactly where it was. Exam writers test the difference between three categories of treatment. Calcium stabilizes the membrane without changing the level. Insulin, beta agonists, and bicarbonate shift potassium into cells temporarily. Binding resins, diuretics, and dialysis actually remove potassium from the body, and a client treated only with shifting agents will rebound when potassium moves back out. Calcium is indicated when the ECG shows changes, or when potassium is severely elevated in a high-risk client, not for a mildly elevated level with a normal tracing. peaked T waves, a widening QRS, a lengthening PR interval, or a lost P wave turn a lab problem into a cardiac emergency, and that is the moment calcium is given. Calcium works within 1 to 3 minutes, far faster than insulin, beta agonists, or dialysis, buying the time those definitive treatments need. Given IV slowly with continuous cardiac monitoring, avoiding bicarbonate lines and caution with digoxin, it changes no laboratory value and saves the client anyway. Question 31. A nurse is preparing to administer IV potassium to a client who has hypokalemia. Which of the following actions should the nurse take? Your options are: A. Give the potassium by rapid IV bolus. B. Administer the potassium subcutaneously. C. Infuse the potassium with an IV pump. D. Push the dose to correct quickly. Don't overthink it. Which one feels right? The correct answer is C. Infuse the potassium with an IV pump. C is correct because IV potassium must be infused slowly with a pump and never bolused, because rapid administration can cause cardiac arrest. The maximum recommended rate keeps the infusion safe for the client. A is wrong because giving potassium by rapid bolus risks fatal cardiac arrest, which is why it is never bolused. The drug must drip slowly within a strict rate limit rather than being delivered all at once. B is wrong because the subcutaneous route is prohibited for potassium because it causes tissue necrosis. Potassium is never given sub-Q or IM, so this route would harm the client and is not an option. D is wrong because pushing the dose to fix the level fast ignores the strict slow infusion requirement. Speeding correction this way could trigger cardiac arrest, defeating the careful pace that potassium replacement demands. Intravenous potassium replacement is one of the most tightly controlled medication administrations in nursing, because the same ion that treats hypokalemia can stop the heart if it arrives too fast. Potassium normally sits at a much higher concentration inside cells than outside, and that gradient sets the resting potential of cardiac tissue. A bolus into a vein spikes the extracellular level near the heart within seconds, faster than cells can absorb it. So the myocardium depolarizes, conduction fails, and the rhythm degenerates into fibrillation or asystole. Every safeguard follows directly from that risk. The drug is always diluted, always run through an infusion pump and never pushed, with strict caps on both concentration and infusion rate, since a rate error here is not recoverable. 2 checks belong in the routine: confirming urine output of at least 30 milliliters an hour before starting, since potassium is cleared by the kidneys, and assessing the site for irritation or extravasation. And no matter how far behind the infusion falls, the rate is never increased to catch up. Unlike ordinary electrolyte replacement, potassium leaves no room for a late or slightly fast infusion. The rate limit isn't about efficiency, it's the line between treatment and cardiac arrest. Question 32. A nurse is reviewing the ECG of a client who has hypokalemia from diuretic use. Which of the following findings should the nurse expect to see? Your options are: A. Flattened T wave, prominent U wave. B. Peak T waves with a widened QRS. C. Tall narrow T waves. D. Shortened QT interval. Got a guess? Lock it in. The correct answer is A. Flattened T wave, prominent U wave. A is correct because hypokalemia produces a flattened T wave, a prominent U wave, and ST depression on the ECG. These changes reflect the altered repolarization caused by a low potassium level. B is wrong because peak T waves with a widened QRS are the signature of hypokalemia, not low potassium. These findings appear when potassium is high and can progress to asystole, the opposite imbalance. C is wrong because tall narrow T waves suggest elevated potassium rather than a deficit. Hypokalemia instead flattens the T wave and adds a U wave, so this tall T pattern points to the wrong direction. D is wrong because a shortened QT interval is not the characteristic change that hypokalemia produces. Low potassium produces a flat T wave and prominent U wave, making the shortened QT an inaccurate expectation here. Low serum potassium leaves a fingerprint on the electrocardiogram distinct enough to diagnose on sight. Understanding why that fingerprint appears means understanding what the T wave and U wave actually represent. The classic sequence is a flattened or inverted T wave, a depressed ST segment, and a prominent U wave, a small deflection normally too tiny to see. Potassium drives repolarization, so when extracellular potassium falls, the potassium channels resetting the cells slow down, dragging that hidden U wave out from behind the T wave. In a normal heart, the U wave is buried in the baseline, but slowed repolarization pulls it into view right after the T wave. That uneven, prolonged recovery across the myocardium is exactly what sets the stage for re-entrant arrhythmias. Premature ventricular contractions, ventricular tachycardia, and torsades de pointe all become more likely as potassium falls. That risk is dramatically amplified when a client is also on digoxin, since low potassium increases digoxin binding to the heart muscle. So a client on both a diuretic and digoxin is a standing hazard exam writers love to test. The direction of the T wave change is the single most reliable clue in electrolyte questions, and anchoring it to the underlying mechanism keeps you from guessing wrong. Remember too, low calcium prolongs the QT interval without a U wave, while low potassium is the one that produces it. Question 33. A nurse is identifying clients on the unit who are at risk for hyperkalemia. Which of the following conditions should the nurse associate with this imbalance? Your options are A. Heart failure, B. Diabetic ketoacidosis, C. Cushing's syndrome, D. Thyroidectomy. Which one is it? Pause the video if you need more time. The correct answer is B. Diabetic ketoacidosis. B is correct because diabetic ketoacidosis is associated with hyperkalemia because the acidosis shifts potassium out of the cells and into the bloodstream, raising the measured potassium level even when total body potassium is not increased. A is wrong because heart failure is linked with hyponatremia rather than high potassium. Fluid retention dilutes sodium in this condition, so it does not produce the elevated potassium seen with acidotic shifts. C is wrong because the electrolyte pattern of Cushing's syndrome tends toward hypernatremia from excess corticosteroid effects, not hyperkalemia. This condition drives sodium retention rather than the potassium elevation that the acidotic shift in ketoacidosis produces. D is wrong because thyroidectomy is associated with hypocalcemia when the nearby parathyroid glands are damaged or removed during the operation. The electrolyte risk it carries involves calcium, not the potassium rise tied to the acidosis of ketoacidosis. Hyperkalemia develops through 3 distinct routes, and knowing which one is in play determines both urgency and treatment. Potassium can fail to leave the body. It can shift out of cells into the bloodstream, or it can be taken in faster than the body can handle it. Reduced excretion is the most common route seen in kidney failure and certain medications. Transcellular shift is the fastest mechanism and the one most often missed on exams. Excess intake from supplements or old stored blood is the least common. In diabetic ketoacidosis, insulin deficiency stops potassium from entering cells, while acidosis forces hydrogen ions inward and potassium outward to preserve electrical neutrality. Both effects push potassium into the serum, even though osmotic diuresis and vomiting have left total body potassium depleted. The lab value shows where potassium is sitting, not how much of it actually exists. The other causes of high potassium sort into these same three categories, while conditions like vomiting, diuretics, corticosteroids, and Cushing syndrome actually lower it. Exam writers test whether you know which pathophysiology moves potassium up, not just which client looks the sickest. Shift-driven hyperkalemia describes redistribution, not true excess. Treating a depleted client as if potassium was surplus is how a manageable emergency becomes a cardiac arrest, which is exactly why insulin waits until potassium is confirmed and replacement is ready. Question 34. A nurse is assessing a client who has hypocalcemia after a parathyroidectomy. Which of the following findings should the nurse expect to observe? Your options are A. Tetany and paresthesia of the fingers. B. Constipation and hyperactive bowel sounds. C. Decreased deep tendon reflexes. D. Flat or inverted T waves. Take a second. Which answer would you pick? The correct answer is A. Tetany and paresthesia of the fingers. A is correct because hypercalcemia causes tetany along with paresthesia of the fingers and lips, muscle twitches, and hyperactive reflexes. Positive Chvostek's and Trousseau's signs further reflect the heightened neuromuscular excitability that a low calcium level produces. B is wrong because constipation and hypoactive bowel sounds belong to hypercalcemia, where excess calcium slows smooth muscle activity. Low calcium instead heightens neuromuscular excitability. So these sluggish gastrointestinal findings reflect the opposite imbalance from the one described. C is wrong because decreased reflexes directly contradict hypocalcemia, which produces hyperactive deep tendon reflexes instead. The increased neuromuscular irritability that defines a low calcium level makes diminished or sluggish reflexes inconsistent with this particular condition. D is wrong because flat or inverted T waves are linked to hypercalcemia and its dysrhythmia risk. Hypocalcemia instead prolongs the QT and ST, so these particular wave changes point to high calcium rather than low. Everything about low calcium comes down to one idea: calcium stabilizes excitable membranes. Take it away and nerves and muscles fire on their own with little or no stimulus needed. This unchecked firing shows up as tetany. It starts as tingling around the mouth and fingertips, progresses to muscle cramps and a claw-like carpopodal spasm with hyperactive reflexes, and in severe cases becomes laryngospasm or seizures. Parathyroid hormone is the body's main calcium regulator, pulling calcium from bone, the kidney, and the gut. After parathyroidectomy or thyroid surgery that damages these glands, that regulation is lost and calcium can fall sharply within hours. Vitamin D deficiency, chronic kidney disease, acute pancreatitis, massive citrated transfusion, alkalosis, and low magnesium can all cause it too. Alkalosis is special. It increases calcium binding to albumin, so a hyperventilating client can develop tingling and spasm even with a normal total calcium. Low calcium and low magnesium both raise excitability, causing tetany and hyperactive reflexes. High calcium and high magnesium do the opposite, causing weakness and diminished reflexes. So flaccid paralysis always points high, never low. Question 35. A nurse plans to assess for Chvostek's sign in a client who has a low calcium level. Which of the following actions should the nurse take? Your options are A. Inflate a blood pressure cuff on the arm. B. Dorsiflex the client's foot. C. Press firmly over the carotid artery. D. Tap the cheek over the facial nerve. Before I reveal it, which one do you think is right? The correct answer is D. Tap the cheek over the facial nerve. D is correct because to elicit Chvostek's sign, the nurse taps the cheek over the facial nerve and watches for facial twitching, a positive response that indicates the neuromuscular irritability of hypocalcemia. A is wrong because inflating a blood pressure cuff tests for Trousseau's sign, not Chvostek's. While both detect hypocalcemia, the cuff produces hand and finger spasm rather than the facial twitch of the cheek tap test. B is wrong because dorsiflex in the foot is a maneuver for assessing other conditions and does not elicit Chvostek's sign. The facial nerve, accessed at the cheek, is the structure tested for this calcium-related response. C is wrong because pressing over the carotid artery is unrelated to Chvostek's sign and could be unsafe. Chvostek's testing targets the facial nerve at the cheek, not the neck vessels, to detect low calcium. Low calcium makes nerves fire when they shouldn't, and 2 bedside tests reveal that irritability before a lab result ever comes back. The examiner taps the facial nerve where it runs superficially near the ear, and a positive response is a same-side twitch that can range from a small pull at the mouth to a spasm involving the eye, nose, and cheek. Extracellular calcium normally binds sodium channels and keeps the threshold for firing high, so when calcium drops, those channels open too easily and a nerve that would normally ignore a tap fires instead. The face isn't special physiologically, it's just where the nerve sits close to the skin. Trousseau's sign uses a blood pressure cuff inflated above systolic pressure for up to 3 minutes, causing ischemia that drops local pH and provokes carpopedal spasm, a rigid cupped hand with wrist flexion and finger extension. Trousseau is generally more specific and rarer in healthy people, so a positive result there carries more diagnostic weight. Both signs are quick screening tools used most often after thyroid or parathyroid surgery, catching early neuromuscular irritability before laryngospasm develops, but neither replaces a serum calcium level. Question 36. A nurse is administering IV calcium gluconate to a client who has life-threatening hypocalcemia. Which of the following actions should the nurse take? Your options are: A. Give the calcium by rapid IV push. B. Administer the calcium intramuscularly. C. Infuse the calcium slowly using a pump. D. Mix the calcium into a bolus. What's your answer? Commit to one before I continue. The correct answer is C. Infuse the calcium slowly using a pump. C is correct because calcium gluconate for life-threatening hypocalcemia must be given slowly through an infusion pump, because administering it too quickly can cause cardiac arrest. Careful pacing keeps the replacement safe. A is wrong because a rapid IV push delivers the calcium too fast and can trigger cardiac arrest. The drug requires a slow, controlled infusion, so pushing it quickly directly violates the safety requirement. B is wrong because the intramuscular route is not appropriate for emergency calcium gluconate replacement. This electrolyte requires slow IV infusion via pump, so giving it IM would not safely or effectively correct the deficit. D is wrong because mixing the dose into a large bolus to run in quickly defeats the need for slow administration. Speeding the calcium this way raises the cardiac arrest risk the controlled infusion is meant to prevent. Intravenous calcium treats symptomatic hypocalcemia when tetany, laryngospasm, seizures, or cardiac changes make oral replacement too slow. But the drug that saves the heart can stop it if given the wrong way. 2 salts are used. Calcium gluconate is safer and preferred for peripheral lines, while calcium chloride has roughly 3 times the elemental calcium and is far more caustic, restricting it mostly to central lines and resuscitation. 3 concerns dominate administration. Speed matters most, since rapid infusion prolongs the cardiac action potential and can cause bradycardia or arrest. Vein integrity matters because extravasation causes tissue necrosis, and incompatibility matters, since calcium precipitates with bicarbonate or phosphate and can occlude the line. A sudden rise in extracellular calcium prolongs the plateau phase of the cardiac action potential, which is why rapid IV push can stop the heart in systole. Slow diluted infusion through a pump with continuous monitoring prevents this. Calcium potentiates digoxin's effect on the heart, so digitalized patients need extra caution. And if hypercalcemia won't correct despite treatment, check magnesium, since it's required for parathyroid hormone to work. Never confuse the two calcium salts, since their elemental content differs substantially. Question 37. A nurse is assessing the client who has hypomagnesemia related to chronic alcohol use. Which of the following findings should the nurse expect? Your options are A. Decreased reflexes and flaccid paralysis. B. Hyperactive deep tendon reflexes and tetany. C. Bounding pulse and hypertension. D. Warm flush skin and lethargy. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is B. Hyperactive deep tendon reflexes and tetany. B is correct because hypomagnesemia increases nerve impulse transmission, producing hyperactive deep tendon reflexes, paresthesias, tetany, and seizures. Positive Chvostek's and Trousseau's signs often accompany the low magnesium level, much as they do in hypercalcemia. A is wrong because decreased reflexes and flaccid paralysis suggest an excess of magnesium, which depresses neuromuscular activity. Low magnesium instead heightens excitability. So these dampened findings reflect the opposite of the deficit the client actually has. C is wrong because A. Bounding pulse and hypertension relate to fluid excess rather than to a magnesium deficit. These cardiovascular findings do not capture the heightened neuromuscular irritability with tetany and brisk reflexes that defines low magnesium. D is wrong because warm flush skin and lethargy do not match the heightened nerve activity of hypomagnesemia. The deficit instead causes brisk reflexes and tetany, making these calm, warm findings inconsistent. Magnesium normally stabilizes excitable membranes and blocks calcium entry at the neuromuscular junction. When magnesium falls too low, that brake is removed and nerves and muscles become hyperexcitable. Findings include hyperactive reflexes, tremor, tetany, and positive Chvostek's and Trousseau's signs. Central nervous system effects range from confusion and agitation to seizures, while cardiac effects include a prolonged QT interval and torsades de pointes. Chronic alcohol use, poor intake, and refeeding syndrome are classic causes. Magnesium is required for parathyroid hormone release, so a magnesium-depleted client cannot raise calcium normally. Magnesium deficiency also causes renal potassium wasting, so both calcium and potassium stay low and refractory until magnesium itself is corrected. Intravenous magnesium is given slowly by pump, since rapid infusion causes hypotension and cardiac arrest. Deep tendon reflexes are monitored because their disappearance is the earliest sign of toxicity, and calcium gluconate is kept available as the antidote. Deficiency of magnesium or calcium produces hyperactive reflexes and tetany, while excess of either produces diminished reflexes, lethargy, and respiratory depression. Anchoring to that single reflex axis lets you reason out nearly every finding without memorizing separate lists. Question 38. A nurse is caring for a client who has respiratory acidosis from hypoventilation. Which of the following findings should the nurse expect? Your options are A. A low carbon dioxide level. B. An elevated bicarbonate level. C. A low bicarbonate level. D. An elevated carbon dioxide level. Which would you go with? Lock it in before the reveal. The correct answer is D. An elevated carbon dioxide level. D is correct because respiratory acidosis results from hypoventilation, which retains carbon dioxide and raises its level because the lungs control carbon dioxide. The respiratory disorders are identified by an abnormal carbon dioxide value, A is wrong because a low carbon dioxide level points to respiratory alkalosis from hyperventilation, the exact reverse of this disorder. Acidosis from hypoventilation builds carbon dioxide up in the blood rather than blowing it off through the lungs. B is wrong because an elevated bicarbonate points to metabolic alkalosis, a problem of the kidneys rather than the lungs. Respiratory acidosis is defined by a carbon dioxide change, not a bicarbonate elevation. C is wrong because a low bicarbonate level signals metabolic acidosis, which arises from bicarbonate loss through routes like diarrhea. This is a metabolic finding, whereas respiratory acidosis is identified instead by retained carbon dioxide from the lungs. Respiratory acidosis happens when arterial pH drops below 7.35 because carbon dioxide builds up in the blood. Carbon dioxide combines with water to form carbonic acid, which releases hydrogen ions and lowers pH. So more carbon dioxide always means a lower pH. At the mechanical level, the cause is always hypoventilation. Opioids and sedatives depress the drive to breathe. Chest, trauma, and neuromuscular disease impair the mechanics of breathing. And COPD, asthma, pneumonia, or pulmonary edema impair gas exchange itself. Carbon dioxide itself is not an acid, but it reacts with water in the blood to form carbonic acid, which splits into hydrogen ions and bicarbonate. The extra hydrogen ions are what actually drive the pH down. Compensation comes from the kidneys and takes hours to days, as renal tubules increase hydrogen excretion and bicarbonate reabsorption. That's why acute respiratory acidosis shows a low pH with normal bicarbonate, while chronic disease shows a near normal pH with clearly elevated bicarbonate, telling clinicians how long the problem has existed. The fastest way to sort any acid-based problem is direction. If pH and carbon dioxide move opposite ways, it's respiratory. Treatment targets ventilation, not the number, because a normal oxygen saturation can still hide dangerous carbon dioxide retention. Question 39. A nurse is caring for a client who is hyperventilating from anxiety. Which of the following acid-base imbalances should the nurse anticipate? Your options are A. Respiratory acidosis, B. Respiratory alkalosis, C. Metabolic acidosis, D. Metabolic alkalosis. Don't overthink it. Which one feels right? The correct answer is B. Respiratory alkalosis. B is correct because hyperventilation from anxiety blows off carbon dioxide and lowers its level, producing respiratory alkalosis. Anxiety reduction and rebreathing techniques help the client retain carbon dioxide and restore balance. A is wrong because respiratory acidosis comes from hypoventilation that retains carbon dioxide, which is the opposite of fast breathing. Hyperventilation from anxiety lowers carbon dioxide, so this rising carbon dioxide disorder does not fit the scenario described. C is wrong because metabolic acidosis stems from a low bicarbonate due to causes like ketoacidosis or diarrhea. It is not produced by rapid breathing, which alters carbon dioxide rather than bicarbonate. D is wrong because metabolic alkalosis results from a high bicarbonate, often from vomiting or antacids. Because hyperventilation affects carbon dioxide and not bicarbonate, this metabolic disorder does not match the anxious client. Respiratory alkalosis happens when carbon dioxide is blown off faster than the body makes it, pushing arterial pH above 7.45 while carbon dioxide falls below 35 millimeters of mercury. Hyperventilation is the mechanism in every single case. The causes split into those that increase the drive to breathe and those that increase it artificially. Anxiety and panic are most common, but pain, fever, early sepsis, salicylate toxicity, hypoxemia, pulmonary embolism, high altitude, and mechanical overventilation all fit the same pattern. Nearly all the symptoms trace back to calcium. Alkaline pH increases calcium binding to albumin. So ionized calcium drops even though the total calcium level looks normal, producing tingling of the lips and fingers, muscle twitching, and carpopetal spasm. Low carbon dioxide also constricts cerebral vessels, causing lightheadedness and fainting even with normal oxygen. Exam writers test whether you assume anxiety is the whole story, when hyperventilation can also be the earliest sign of pulmonary embolism, sepsis, or salicylate poisoning. Treatment means slowing the breathing, calming the client, and fixing the underlying cause, never a paper bag. Respiratory alkalosis and respiratory acidosis are exact opposites, separated only by the direction carbon dioxide moves. Question 40. A nurse is caring for a client who has diabetic ketoacidosis. Which of the following findings should the nurse expect with the associated acid-base imbalance? Your options are A. Kussmaul respirations, B. Numbness and tingling with tetany, C. Tinnitus and finger numbness, D. Tachycardia from anxiety only. Got a guess? Lock it in. The correct answer is A. Kussmaul respirations. A is correct because diabetic ketoacidosis causes metabolic acidosis with a low bicarbonate, and the client develops Kussmaul respirations. These rapid, deep breaths are the lungs compensating by blowing off carbon dioxide to raise the falling pH. B is wrong because numbness, tingling, and tetany are features of metabolic alkalosis, not metabolic acidosis. These signs reflect a high bicarbonate state, so they do not match the acidosis driven by ketoacidosis. C is wrong because tinnitus and finger numbness point to respiratory alkalosis from hyperventilation. While salicylate toxicity can begin that way, the ketoacidosis here produces metabolic acidosis and its deep Kussmaul breathing. D is wrong because tachycardia attributed to anxiety alone fits respiratory alkalosis, rather than the acidosis of ketoacidosis. Choosing it overlooks the deep, compensatory Kussmaul respirations that truly distinguish the metabolic acidosis developing in this client. Kussmaul respirations are deep, rapid, laborious breaths seen in severe metabolic acidosis. They are the body's most visible attempt to fix a chemistry problem using the lungs, and they're distinguished from ordinary fast breathing by their striking depth. In diabetic ketoacidosis, insulin deficiency forces the body to burn fat instead of glucose, producing ketoacids that consume bicarbonate and drive pH down. Chemoreceptors sense this and drive ventilation upward, so every deep breath expels carbon dioxide, lowering carbonic acid and pushing pH back toward normal. The labs make the compensation visible. pH and bicarbonate fall together, marking the problem as metabolic, while carbon dioxide drops separately because the lungs are working to fix it. The fruity odor comes from acetone, a volatile ketone body that is exhaled and detectable at the bedside, pointing specifically to ketoacidosis. Treatment follows a fixed order. Intravenous fluids come first since volume depletion is the most immediate threat. Then a regular insulin infusion to stop ketone production, and potassium replacement as levels fall with treatment. Bicarbonate is reserved only for extreme acidosis. The key nuance exam writers test is direction. Metabolic acidosis produces deep, rapid compensatory breathing, while metabolic alkalosis produces slow, shallow breathing as the body retains carbon dioxide. Shallow breathing in a DKA client signals exhaustion and collapse, not the expected pattern. Question 41. A nurse is caring for a client who has been vomiting for an extended period. Which of the following acid-base imbalances should the nurse anticipate? Your options are A. Metabolic acidosis, B. Respiratory acidosis, C. Respiratory alkalosis, D. Metabolic alkalosis. Which one is it? Pause the video if you need more time. The correct answer is D, metabolic alkalosis. D is correct because prolonged vomiting causes loss of gastric acid and a resulting accumulation of bicarbonate, producing metabolic alkalosis. Treatment targets the underlying cause with antiemetics and careful replacement of the lost fluids and electrolytes. A is wrong because metabolic acidosis develops from a low bicarbonate, as seen with diarrhea or ketoacidosis. Vomiting instead removes acid and raises the bicarbonate level, so it drives the imbalance in the opposite alkalotic direction. B is wrong because respiratory acidosis arises from hypoventilation and retained carbon dioxide, a lung problem. Vomiting alters bicarbonate through gastric acid loss, not carbon dioxide, so this respiratory disorder does not apply. C is wrong because respiratory alkalosis comes from hyperventilation that lowers carbon dioxide through the lungs. Because the imbalance from vomiting involves bicarbonate rather than breathing, this carbon dioxide-driven disorder does not fit the scenario described. Metabolic alkalosis is a rise in blood pH above 7.45 caused by losing acid or gaining bicarbonate, and the lab signature is a high pH paired with a high bicarbonate above 26. Prolonged vomiting and gastric suction are the classic causes. Normally, acid pumped into the stomach is bounced by bicarbonate that later gets neutralized when the pancreas buffers acidic chyme in the duodenum. Vomiting breaks that loop. Acid leaves through the mouth. The compensating bicarbonate stays in the blood, and the blood grows more alkaline with each episode. Vomiting also drains fluid, sodium, chloride, and potassium, and the kidney responds by conserving sodium through aldosterone, which trades sodium reabsorption for hydrogen and potassium loss. Instead of dumping bicarbonate to fix the alkalosis, the kidney excretes more acid, deepening the problem until chloride and volume are replaced. The exam distinction is direction. A high pH with high bicarbonate is metabolic alkalosis, moving together, while a high pH with low carbon dioxide is respiratory alkalosis, moving apart. That's why metabolic alkalosis causes slow, shallow breathing as compensation, the opposite of the fast breathing that causes respiratory alkalosis. Treatment replaces what vomiting took away. Isotonic saline restores volume and chloride, so the kidney can stop hoarding sodium and start excreting bicarbonate, while potassium is replaced and the underlying cause is treated. Remember the bicarbonate value. It's what separates this from respiratory alkalosis in one glance. Question 42. A nurse is caring for a client who has confusion and rapid deep breathing after an aspirin overdose. Which of the following acid-base imbalances should the nurse identify? Your options are A. Metabolic alkalosis, B. Respiratory acidosis, C. Metabolic acidosis, D. Uncompensated fluid excess. Take a second. Which answer would you pick? The correct answer is C. Metabolic acidosis. C is correct because aspirin overdose ultimately produces metabolic acidosis with a low pH and a low bicarbonate level. The rapid, deep respirations the client shows represent the body attempting to compensate by exhaling more carbon dioxide. A is wrong because metabolic alkalosis involves a high bicarbonate from causes like vomiting or antacids. Salicylate toxicity drives bicarbonate down, so the alkalotic state is the reverse of what this client develops. B is wrong because respiratory acidosis reflects retained carbon dioxide from hypoventilation, yet this client is breathing rapidly and deeply. That fast breathing lowers carbon dioxide as compensation, which contradicts a carbon dioxide retaining disorder. D is wrong because uncompensated fluid excess is a volume problem, not the acid-base disturbance the question targets. Aspirin overdose disrupts hydrogen ion balance and produces metabolic acidosis rather than a fluid imbalance. Aspirin overdose creates one of the most distinctive acid-base pictures in medicine. built from two effects that start at different times. Understanding which one dominates is the key to reading the labs correctly. Aspirin first stimulates the medulla, driving hyperventilation and an early respiratory alkalosis. But it also poisons cellular metabolism, and that second effect produces a metabolic acidosis that comes to dominate as toxicity progresses. Salicylate uncouples oxidative phosphorylation in the mitochondria. So the electron transport chain keeps running while usable energy production stops. Cells burn fuel and release it as heat, causing hyperthermia, and shift to anaerobic metabolism, generating lactic acid, keto acids, and salicylic acid itself, all of which consume bicarbonate and drop the pH. Because acidosis pushes more salicylate into its uncharged brain-penetrating form, alkalinizing the blood and urine with bicarbonate reverses that gradient and traps the drug for excretion. Crucially, the rapid deep breathing is compensation, not the primary problem. So sedating or intubating these clients without matching their ventilation can cause the pH to collapse. When you see a low pH with a low bicarbonate alongside deep rapid breathing, trust the numbers. This is metabolic acidosis with respiratory compensation, not respiratory alkalosis. The values, not the appearance of the breath, tell you what is really happening. Question 43. A nurse is monitoring a client who is receiving moderate sedation for a procedure. Which of the following findings should the nurse expect? Your options are: A. The client responds to verbal stimuli. B. The client has lost the gag reflex. C. The client cannot maintain an airway. D. The client is unresponsive to all stimuli. Before I reveal it, which one do you think is right? The correct answer is A. The client responds to verbal stimuli. A is correct because during moderate sedation, the client responds to verbal stimuli, retains the gag reflex, and maintains a patent airway. A dedicated ACLS certified nurse monitors the client continuously throughout the procedure. B is wrong because loss of the gag reflex is not expected with moderate sedation, which preserves protective reflexes. A diminished gag reflex would indicate deeper sedation than this level, where airway protection remains intact. C is wrong because inability to maintain an airway describes general anesthesia rather than moderate sedation. Under moderate sedation, the client keeps a patent airway, so airway loss would signal a different, deeper level. D is wrong because complete unresponsiveness reflects general anesthesia, not moderate sedation. The whole point of moderate sedation is that the client still responds to verbal stimuli, which an unresponsive client would not. Moderate sedation, once called conscious sedation, keeps a client responsive to voice or light touch while breathing, airway, and heart function stay intact on their own. That preserved responsiveness is the whole point of the technique. Sedation is a continuum, not four separate boxes. Minimal sedation leaves normal responses to verbal commands. Moderate sedation produces purposeful response to voice or light touch. Deep sedation needs repeated or painful stimulation before any response appears. And general anesthesia produces no response at all, with the airway fully managed for the client. Protective reflexes are the bedside markers separating the levels. As long as gag and cough reflexes remain intact, the airway needs no support. But losing the gag reflex signals the client has slipped into deep sedation and is now at risk for aspiration. Because a client can drift deeper than intended, a dedicated nurse monitors continuously and performs no other task. Saturation, heart rate, blood pressure, respiratory rates, and consciousness are tracked throughout. And capnography is increasingly standard because it catches hypoventilation before saturation even drops. A client who rouses to voice or touch, keeps breathing on their own, and maintains a steady waveform is exactly where moderate sedation intends them to be. Unresponsiveness is never the goal here. That's the line into deep sedation and general anesthesia. Question 44. A nurse is caring for a client who developed hypotension and tachycardia after receiving midazolam during a procedure. Which of the following medications should the nurse anticipate administering? Your options are A. Naloxone, B. Atropine, C. Dantrolene, D. Flumazenil. What's your answer? Commit to one before I continue. The correct answer is D. Flumazenil. D is correct because flumazenil reverses benzodiazepines such as midazolam, so the nurse anticipates giving it when the client reacts adversely to the sedative. This reversal agent counteracts the benzodiazepine's effects and helps restore the client's stability. Is wrong because naloxone reverses opioids, not benzodiazepines, because midazolam is a benzodiazepine rather than an opioid. Naloxone would not counteract its effects in this client and is the wrong reversal agent. B is wrong because atropine treats bradycardia by increasing heart rate and does not reverse benzodiazepine sedation. It addresses a slow pulse, so it would not resolve a reaction caused specifically by midazolam. C is wrong because dantrolene is the drug for malignant hypothermia, an entirely different emergency. It does nothing to reverse a benzodiazepine, so it has no role in managing this client's reaction to midazolam. Flumazenil is the specific antidote for benzodiazepine sedation, and understanding how it works explains every rule around its use. Flumazenil binds the exact same site on the GABA receptor that midazolam, lorazepam, and diazepam occupy, but it produces no effect of its own. By physically displacing the benzodiazepine through competitive inhibition, it lifts sedation and reverses respiratory depression within 1 to 2 minutes. Midazolam is unpredictable because the same dose that sedates one client can cause apnea in another, older adults, people with liver disease, and anyone who has also received an opioid are especially sensitive, since the combination compounds rather than simply adds. Flumazenil is avoided in clients with a seizure disorder controlled by benzodiazepines and in tricyclic antidepressant overdose, because stripping away the benzodiazepine's anticonvulsant protection can trigger seizures that are then extremely hard to control. Flumazenil wears off faster than most benzodiazepines, so a client can appear fully awake and then resedate without warning. That's why continuous monitoring for at least 2 hours is standard, and why nobody is discharged simply because they look alert. Question 45. A nurse is caring for a client during surgery who develops early signs of malignant hypothermia. Which of the following actions should the nurse anticipate? Your options are A. Continuing surgery while observing the client, B. Administering dantrolene and stopping surgery, C. Withholding oxygen until the temperature rises, D. Applying warming blankets to the client. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is B. Administering IV dantrolene and stopping surgery. B is correct because for malignant hypothermia, the team administers IV dantrolene, terminates the surgery, gives high-flow oxygen, and cools the client with iced fluids and a cooling blanket to halt the crisis. A is wrong because continuing the surgery allows this life-threatening reaction to keep worsening. The correct response is to terminate the procedure immediately. So proceeding while merely observing the client would place that client in serious danger. C is wrong because withholding oxygen is dangerous because the client needs high-flow oxygen during this crisis. Waiting for the temperature to climb ignores that an extremely high temperature is a late sign, not a trigger to act. D is wrong because warming blankets would raise body temperature and intensify the hypothermia. Management calls for cooling with iced fluids and a cooling blanket, so adding warmth directly opposes the needed treatment. Malignant hypothermia is a rare, inherited muscle disorder triggered by volatile anesthetics and succinylcholine, in which calcium floods the muscle cell and cannot be pumped back out, driving a fatal metabolic cascade without immediate treatment. The problem lives in one protein, a mutated ryanodine receptor on the sarcoplasmic reticulum that opens excessively and won't close. Calcium pours into the cytoplasm, forcing continuous muscle contraction that burns through ATP, consumes oxygen, and generates heat and lactic acid until the cell membrane fails. The earliest reliable sign isn't fever, it's rising end-tidal carbon dioxide that won't respond to increased ventilation, unexplained tachycardia, masseter rigidity after succinylcholine, generalized rigidity, and tachypnea all appear early, while hypothermia itself shows up late, after the process is already well advanced. Dantrolene is the only drug that stops the process at its source, blocking calcium release from the sarcoplasmic reticulum, so it always takes priority over choline, which only treats a symptom. Calcium channel blockers are contraindicated alongside dantrolene because the combination can cause dangerous hyperkalemia and cardiovascular collapse. In the operating room, rising carbon dioxide and jaw rigidity demand action before the temperature ever climbs. Shut off the trigger agent and reach for dantrolene immediately. Question 46. A nurse is caring for a client who develops a systemic toxic reaction to a regional anesthetic block. Which of the following actions should the nurse take? Your options are: A. Monitor the creatinine level. B. Position the client on the right side. C. Provide airway support. D. Administer a diuretic. Which would you go with? Lock it in before the reveal. The correct answer is C. Provide airway support. C is correct because a systemic toxic reaction to a regional block causes central nervous system depression. So, the nurse provides airway support to protect breathing while the toxic effects are managed. A is wrong because monitoring creatinine assesses kidney function and does nothing for the immediate respiratory threat of CNS depression. The toxic reaction endangers the airway, which this lab check fails to address. B is wrong because right side positioning is not the indicated response to anesthetic toxicity. The priority is supporting the airway against depressed breathing, so a specific side-lying position does not meet the urgent need. D is wrong because giving a diuretic targets fluid removal, which is unrelated to a systemic anesthetic reaction. It would not counter the central nervous system depression that requires airway protection in this client. Local anesthetic systemic toxicity happens when lidocaine, bupivacaine, or ropivacaine reach the bloodstream in high enough concentration to affect the brain and heart, usually from accidental intravascular injection, absorption from a vascular site, or cumulative dosing. Bupivacaine carries the highest cardiac risk. Local anesthetics work by blocking voltage-gated sodium channels to stop nerve depolarization around a peripheral nerve that produces anesthesia, but in the systemic circulation, that same blockade reaches the brain and the heart's conduction tissue. CNS signs come first because the brain is more sensitive. Circumaural numbness and metallic taste appear early, followed by tinnitus, dizziness, and confusion, then agitation and seizures, and finally CNS depression with unconsciousness and respiratory arrest. Cardiovascular collapse usually follows, though with bupivacaine it can strike first or simultaneously. The same sodium channel blockade produces useful anesthesia at the peripheral nerve, but causes toxicity when it reaches the central nervous system and cardiac conduction tissue, since sodium channels are equally essential in all three locations. Management starts with airway because hypoxia and acidosis worsen toxicity by increasing the drug's affinity for sodium channels. Oxygen and ventilation are given immediately. Lipid emulsion follows as a specific antidote. And benzodiazepines control seizures, while resuscitation continues with smaller epinephrine doses and no antiarrhythmics that share the same sodium channel mechanism. Question 47. A nurse is preparing a client for surgery and reviewing the informed consent. Which of the following actions is within the nurse's role? Your options are A. Explaining the surgical risk and benefits. B. Witnessing the client's signature on the consent. C. Describing alternatives to the procedure. D. Obtaining the consent from the client. Don't overthink it. Which one feels right? The correct answer is B. Witnessing the client's signature on the consent. B is correct because the nurse witnesses the client's signature, verifies understanding and competence, and clarifies information. The provider, not the nurse, obtains consent and explains the procedure, risks, benefits, and alternatives. A is wrong because explaining the surgical risks and benefits is the provider's responsibility, not the nurse's. The nurse may reinforce understanding but cannot supply this new information that the provider must deliver when obtaining consent. C is wrong because describing alternatives to the procedure also belongs to the provider during the consent discussion. The nurse's role is limited to witnessing and clarifying, so presenting treatment options exceeds that scope. D is wrong because obtaining the consent itself is a provider function. The nurse only witnesses the signature and confirms the client understands. So actually, securing the consent falls outside the nurse's authority. Informed consent is more than a signature. It's a legal and ethical process grounded in autonomy. And it belongs to one person only, the provider performing the procedure. The provider alone must explain the procedure's nature and purpose, its benefits, its risks, and the alternatives, including what happens if the client declines. Only the person performing the procedure can be held accountable for that conversation. Valid consent requires three things at once. The client must be competent to understand and appreciate consequences. The decision must be voluntary and free of pressure, and the disclosure must be adequate. That's also why sedation is only given after the form is signed. No, it would erase competence. The nurse's role is narrow and specific, witnessing that the right person is signing voluntarily and appearing competent, then confirming the form is complete and in the chart. Witnessing the signature confirms the act of signing, not the quality of the explanation behind it. If a client shows confusion or misunderstanding, the nurse stops and pages the provider rather than answering questions personally. The signature is never the point. The understanding behind it is. Question 48. A nurse is reviewing pre-operative laboratory results for a client scheduled for surgery. Which of the following values should the nurse report to the provider? Your options are A potassium level within the expected range. B, a sodium level within the expected range. C, an elevated white blood cell count. D, a hematocrit within the expected range. Got a guess? Lock it in. The correct answer is C, an elevated white blood cell count. C is correct because an elevated white blood cell count suggests infection and should be reported before surgery. Other abnormal results, such as a high creatinine or high glucose, also warrant notifying the provider pre-operatively. Is wrong because a potassium level within the expected range is normal and needs no report. The nurse alerts the provider only to abnormal pre-operative findings, so a value in range does not require notification. B is wrong because a sodium level within the expected range reflects normal status and is not a concern. Reporting focuses on values signaling infection or organ impairment, which a normal sodium does not represent. D is wrong because a hematocrit within the expected range indicates no immediate preoperative problem. Because it is normal, it does not meet the criteria for the abnormal result that should prompt notifying the provider. Before surgery, the nurse's job is not to diagnose but to catch lab values that could threaten anesthesia, safety, or surgical outcomes and get them to the provider in time to act. An elevated white blood cell count carries special weight because of what it implies about infection. Surgery on an infected client risks seeding the surgical site, delayed healing, sepsis, and if hardware is being implanted, a catastrophic implant infection. That's why an unexplained elevation before an elective procedure often means postponement. Every other preoperative value follows the same question. What could go wrong under anesthesia? Hemoglobin and hematocrit reflect oxygen reserve. Platelets and INR predict bleeding. Potassium risks arrhythmias. Glucose affects healing. Creatinine and bun show renal clearance, and liver studies affect drug metabolism. Picture a nurse in mobile reviewing labs for a knee replacement patient. Her white count is well above range with nothing in the chart to explain it. So the nurse checks her temperature, asks about urinary symptoms, and calls the surgeon before transport. The real skill is in reporting every abnormal number equally. That just buries the finding that matters. It's recognizing which deviation actually changes the risk of the procedure ahead, documenting it, and following the chain of command until someone responds. Question 49. A nurse is preparing a client for a laparotomy and finds the client has an elevated temperature. Which of the following actions should the nurse take? Your options are: A. Notify the surgeon. B. Transfer the client to the operating room. C. Apply ice packs to the client. D. Encourage the client to drink fluids. Which one is it? Pause the video if you need more time. The correct answer is A. Notify the surgeon. A is correct because an elevated temperature before a laparotomy suggests a possible infection and may lead to cancellation. So the nurse notifies the surgeon rather than proceeding with the planned procedure on a potentially unstable client. B is wrong because transferring the client to the operating room proceeds with surgery, despite a sign of possible infection. The fever must be reported first, since it could prompt postponing the procedure the surgeon decides about. C is wrong because applying ice packs treats the temperature without addressing why it is elevated. This action skips notifying the surgeon, who must evaluate the fever as a potential reason to cancel surgery. D is wrong because encouraging fluids does not resolve the underlying concern and would be inappropriate when the client is likely NPO before surgery. The fever itself requires the surgeon's attention, not increased intake. Preoperative fever is one of the clearest signs a surgeon must be notified before a procedure begins, because it may signal an active infection that turns a planned surgery into a much higher risk one. The risks compound in several directions. Anesthesia and surgical trauma suppress immune function, allowing bacteria to seed the surgical site or implants, impair wound healing, and raise the risk of sepsis. Before a laparotomy, fever could reflect a harmless respiratory or urinary infection, or it could be the first sign the abdominal condition has progressed to perforation, abscess, or peritonitis, and only the surgeon can weigh which it is. The decision to postpone, proceed, or treat belongs to the surgeon. The nurse's job is assessment and escalation, gathering findings like temperature trends, breath sounds, and abdominal pain, then paging the surgeon before the client is transported, giving an antipyretic, documenting and moving on, or rechecking later or delay the one action that matters, notifying the surgeon while the plan can still change. This is different from postoperative fever, which is expected and managed differently. Question 50. A nurse in the PACU is caring for a client who remains unresponsive after general anesthesia. Which of the following actions should the nurse take first? Your options are: A. Place the client in semi-Fowler's position. B. Position pillows under the client's knees. C. Place the client flat with legs elevated. D. Place the client in a lateral position. Take a second out. Which answer would you pick? The correct answer is D. Place the client in a lateral position. D is correct because for an unresponsive PACU client, the nurse first places them in a lateral, side-lying position because aspiration is the greatest risk. This position lets secretions drain and protects the airway. A is wrong because semi-Fowler's is appropriate once the client is responsive, not while unresponsive. Until the client can protect the airway, side-lying guards against aspiration better than sitting them up in this position. B is wrong because placing pillows under the knees is avoided after surgery because it impairs venous return. It also fails to address the aspiration risk that makes positioning the unresponsive client on the side the priority. C is wrong because lying flat with legs elevated is used for hypotension, not routine airway protection. For an unresponsive client, the immediate concern is aspiration, which the lateral position addresses more directly than leg elevation. In the post-anesthesia care unit, the top nursing priority is always the airway, because general anesthesia strips away the reflexes that normally keep it open and clear. In an unresponsive client, the tongue itself is the most common cause of obstruction. Falling back against the throat when muscles relax from anesthesia, the lateral or recovery position uses gravity to pull the tongue forward while letting secretions and vomit drain out instead of pooling. Positioning the client on their side opens the airway and protects it from aspiration at the same time, with no equipment and no delay, which is exactly why it comes before suction, oxygen, or any other intervention. Once the airway is secured, the rest of recovery runs continuously. Respiratory rate and oxygen saturation, frequent vital signs, level of consciousness as the client wakes, and temperature, pain, and nausea as they become able to report them. Oxygen delivered to a blocked airway never reaches the lungs, so the recovery position always comes first. It's the one action that makes every other intervention possible. That wraps up our question and answer review of Foundations of Nursing Care. If you'd like to keep practicing, head over to our website where you'll find hundreds of free practice questions along with full, detailed study guides ready and waiting for you. Everything is linked right below in the description, so you can jump in immediately, keep learning at your own pace, and keep building your confidence every single step along the way. Subscribe so you don't miss our next review, and good luck on your ATI Adult Medical Surgical exam.